Hello, good evening, and namaskar to everyone. It's a pleasure to welcome you all for Hematology Updates 2023, updates from EHA 2023. This is a virtual program which will be done under the aegis of Cancer Research and Strategic Foundation. It's a great pleasure to welcome and invite our program convener, Dr. Upendra Sharma sir, Senior Consultant Hematologist and Hemato-Oncologist from the prestigious Bhagwan Mahavir Cancer Hospital, Jaipur. Once again, very warm welcome and a great good evening to everyone. Sir, Dr. Upendra Sharma sir, good evening to you, and we give the floor to you for your welcome and introduction, please. Over to you, sir. Dr. Upendra Sharma sir, good evening. You need to unmute and start the proceedings, please. Dr. Upendra sir, you have muted yourself. Upendra sir, आपने म्यूट किया हुआ है. Can you just unmute, please? Yeah, Dr. Upendra sir, good evening. Can you just start the proceedings, please? Hello, Dr. Upendra sir. Hello, Dr. Upendra sir, can you hear us? Yeah, good evening, Dr. Bapna sir. Sorry for this. Let's just give us a minute, sir.
Call him on his mobile.
Yeah, I'm doing it, sir. Hello, Dr. Upendra sir, can you hear us?
मेरे को आवाज नहीं आ रही, क्या बात है? मेरी आवाज आ रही है आपको?
Yes, sir, we can hear you, sir. Yeah. Dr. Upendra sir, we can hear you. Yeah, Dr. Upendra sir, please start.
I think Dr. Upendra has to log out and re-log in. That might help.
Sir, can you hear my voice?
Yes, sir.
Today, good evening, everybody. Today, we are here to discuss about hematology, what has happened in June this year at Germany, Frankfurt. Today, we have various international speakers, or various national speakers. We'll be discussing about in the field of hematology. We'll be discussing about various aspects of leukemia, lymphomas, and myeloma. For this, I invite Dr. Ajay Bhapna sir. He is head of department at Bhagwan Mahavir Cancer Hospital. He is always there to bless us with his blessings in various academic events. To Bhapna sir for opening remarks and inauguration of this conference. Bhapna sir, please.
Thank you, Upendra, for the kind words. And at the outset, I would like to thank all the organizers for giving me the opportunity to speak on the inaugural session of Hematology Express. And this is the another edition of Hematology Express, which will really enlighten most of the faculty and the participants who are attending this meeting. As usual, when I was looking at the academic program, so the faculty and the topics have been chosen very wisely. I think with every bit of minute of this Hematology Express, all the delegates are going to really enjoy and will enrich their knowledge so that they can apply the data of EHA 2023 in their practice. And for this first day session, we have chairpersons Dr. Lalit Sharma, who is a senior medical oncologist at Manipal Hospital, and Dr. Ashish Verma, who is a transplant physician at Apex Hospital. So over to chairperson for the further proceedings. Thank you very much, Dr. Upendra, again. You can start the proceedings, chairpersons.
So yeah. So good evening to all. Am I audible to all? Am I audible, sir?
Yes, sir. Yes.
Yes.
Okay. Good evening. Good evening to all. So we are proceeding with our first session. So for that, Dr. Lalit sir and me are chairing the session. So we are inviting our first speaker, Dr. Meet Kumar. He is from Gurugram. He is delivering the talk on the topic immunotherapy approaches in AML, potential and challenges. So over to you, Dr. Meet Kumar. Thank you.
Thank you so much, Dr. Ashish. I'll just project the slides. So are my slides visible?
Yes, sir.
Yes, sir.
Okay. So like at the outset, I must say, convey a big thank you to the organizers, the program convener, Dr. Upendra Sharma, who is a real senior to me, and all the organizing committee who are present here for giving me this topic, and that also as an opening batsman. So I have a sort of a fear for serving as an opening batsman. But today I'll try to do justice to the topic that is being given to me, that is immunotherapy in AML. So I must say that before I start, what I should be telling is that the topic of immunotherapy in AML is in the initial and evolving phases. We have an enemy with us that is called acute myeloid leukemia. All our weapons that are available to us so far in terms of clinical weapons are good to a certain extent, but we all as clinical hematologists know that we have got limited utility of many of these weapons, because most of the times we are left with disappointment in terms of clinical outcomes. So when I say that AML is a dreaded disease, the weapons, the options, the treatment molecules that are available to us are having major limitations in being able to control the disease for a prolonged period. Overall survival, prolonged remission, relapse-free survival are the most dismal across all hematological blood cancers in this cohort of disease. And that is why there is a need and pressing need to develop newer frontiers, open up newer frontiers, and try to address those challenges of poor outcomes in these high-risk blood cancer or hematological malignancy patients. We all know that whatever be our area of practice, whatever be our institute of practice, what we face is most of the patients will not be living more than 40% of the patients might not be living for more than 5 years, 7 years, with whether they are good risk AML or poor risk AML. That is what has been our clinical practice in general so far. So that is the need. The transplant as a cellular therapy is good and effective for intermediate risk and high risk of acute myeloid leukemia, but it has its own limitations, coming up with a transplant related morbidity and mortality, high risk of infections that limits its toxicities and long-term efficacies. So we are going back to saying that there is an immune system that has been weakened by the acute myeloid leukemia that the patient has, and that immune system is sleeping, and that immune system needs to be wakened up. It needs some jerking so that it wakes up and it starts to do the job that the treatment molecules or the chemotherapy molecules so far available to us are trying to do. So whether that can be achieved, how far we have reached in that scenario, that is what we are trying to look at. In acute lymphoblastic leukemia, we have all seen the utility of CAR-T. We talk about monoclonal antibodies, and they have shown good response, be it inotuzumab, be it blinatumomab. We have all seen good responses in clinical outcomes when it was implemented for refractory and relapsed acute lymphoblastic leukemia. But whether that promise holds true also for acute myeloid leukemia, That is what we are here to discuss today. Disappointingly, I would say that immunotherapy in AML is still in its nascent stages. It is in the evolving stages, and whatever limited data options that we have today, that we will be discussing. So what is the basic principle on which immune therapy is working? I'll just explain by means of this cartoon. If we talk of the B cartoon, the cartoon B, that is, it is showing the activity of the humoral immune response. So we all know that there is humoral immune response and there is a cellular immune response. When we talk about humoral immune response, that means antibody mediated ADCC and CDCC activity, because of which the tumor cells or the infections, whatever the target antigen is, gets destroyed. So similarly, whether that type of humoral response can be elicited against the tumor cells, in our case specifically against acute myeloid leukemia. So there are monoclonal antibodies that target different antigens on the surface of the AML cells, and those antibodies can elicit response by tumor kill by means of ADCC and CDCC mechanisms. That is for the humoral immune response. So the most common antibodies that are available to us is CD33 antibody, the gemtuzumab or ozogomycin that we have used and listened and talked to about for long, and some more antibodies that I shall be talking in the next few slides. Then there is about the cellular immune response. So what is cellular immune response? There are three different components to cellular response. That means T cell will kill the acute myeloid leukemia cells. So if we talk about the cartoon A, that is called as checkpoint inhibition. What is checkpoint inhibition? We all know that checkpoint inhibition, basically what it means is that there are breaks in the immune system that the God has given to human beings to prevent the killing of the normal innate human cells. So self-antigen destruction is prevented because of the existence of the checkpoint inhibition. That means the T cells that are present in the body, they have the braking system so that they don't destroy own cells because of the presence of MHC. So now the AML cells are supposedly more smarter than us, and so what they do is they upregulate MHC. What happens because of the upregulation of MHC in the tumor cells, that the T cells recognize them as self and try to not destroy them. Instead of destroying, they are not able to destroy them because of the upregulation of MHC, and that ultimately leads to immune escape of the tumor cells and what is also called as immune tolerance, because immune cells are not able to do their job because the tumor cells are masquerading as self cells. So what can be done for that? If we can somehow remove these breaks from the T cells, that can somehow rapidify the tumor kill of the T cells. How can that be achieved? So there are these breaks, most common breaks that are present on the T cells are called as checkpoints, and the most common checkpoints that have been most intensively studied for most of the solid and liquid tumors are the PD-1, the most commonly used anti-PD-1 PD-1 antibodies are nivolumab and pembrolizumab and molecules like that, and the CTLA-4 the antigen CTLA-4 that acts as a break point or the checkpoint on the T cells that prevents it from identifying tumor cells as self. So if we can remove and produce antibodies against these antigens, the tumor cells, T cells, can be activated against the tumor cells, thereby achieving the target of tumor kill. The next is what you can see in the cartoon number D, that is genetically engineered T cells. We plant the antigens of the tumor into the host T cells by autologous T cell collection. They are genetically identified. They are infused back into the patient, and once they're infused back, what they do is they are already primed to kill a specific tumor antigen that they have been exposed to, and that serves the purpose of that tumor of the chimeric antigen receptor T cells. They go on as a weapon and kill the tumor cells, specifically targeting the antigen against which they have been primed. So that is about the CAR T cells. The last is the C cartoon, that is the cancer vaccines. We have all heard about cancer vaccines for years. The limitation about the cartoon A and D is that they are harnessing the potential of T cells, T immune cells of the body. The problem with T cells is that they do not recognize tumor cells alone. What they do is they have some cross reactivity, and that is the reason with these type of approaches we do see autoimmune phenomenon being present with the use of both checkpoint inhibitions and with CAR T therapies. So that autoimmune phenomenon is essentially existent because of the T cells that are being used for this purpose. So how can we overcome that? What is being done in the cancer vaccines of the evolution of the cancer vaccines is, instead of T cells, monocytes or the dendritic cells are being harnessed to serve this potential. They are MHC non-restricted, and because of that, they only perform the purpose of tumor kill and do not lead to the side effect of autoimmunity. So this is broadly the outlay of what the immunotherapies are sort of being tried. So none of them is actually in clinical practice, day-to-day clinical practice. But yes, we are talking about EHA 2023. Hematology Express is a wonderful name given to this conference. I really appreciate that. And that is what we're trying to do. We are trying to fast track a few years later what we will be using in our country. This is what we are discussing today on this platform. So talking one by one, monoclonal antibody. So we discussed they are functioning by CDCC and ADCC mechanisms. So the most commonly used antibody target is anti-CD33. The interesting thing is the patients, these type of AML patients with complex karyotype have got a down-regulated CD33, while patients with FLT3 or NPM mutated AML have got a higher expression of CD33. So what I'm trying to indirectly say is, if there is no correlation as such as of today that gemtuzumab will be more useful in patients with FLT3 or NPM1 mutated AML, but yes, CD33 expression is something that is what we are looking at, and there is more research going on that which specific mutations will be these anti-CD33 molecules will be used. We all are aware of the history of Mylotarg. It was launched in 2000, but because of the hepatic VOD increased incidence, it was withdrawn from the market, but it was relaunched after a couple of trials that showed the utility of fractionated dosing of GO, that is Mylotarg, at 3 milligrams per meter square and on day 1, 4, and 7. Those of us who have used this molecule know that even this dose is toxic, and many times we try to reduce the dose to this, from instead of 3 doses in a cycle to 1 or 2 doses in a cycle. And that also has shown side effects, yet efficacy in these patients. So the fractionated dosing schedule of GO is something being extensively studied, and some of the trials have shown good response to these molecules when either used as single agent or in combination. The major limitation with GO is the side effect of VOD, hepatic VOD. So what can be done to prevent this side effect? So newer sort of advances are being achieved, and newer advances are being done, and newer molecules are being generated. So one of the such molecules is this SGN-CD33A, wherein instead of ozogomycin, the drug is used is pyrrolobenzodiazepine, PBD, as a dimer in the ADC conjugate. And this the beauty of this molecule is that this has shown higher response rates in the phase 1 clinical trials as compared to GO, and also the chances of VOD was almost negligible. The 60-day mortality in initial trials was less than 10%. So again, this is an advancement that is happening in CD33 antibodies over and above the Mylotarg. Another molecule that is being used and implemented in phase 1 trials is this lintuzumab, that is basically a radioimmunoconjugate along with anti-CD33 antibody, which incorporates actinium-225 and bismuth-213 as a radioisotope along with the anti-CD33 antibody. It again serves its purpose by practically negligible incidence of hepatic VOD. And the problem is that so far the efficacy as compared to the molecule, the SGN-CD33A, is limited. So more research is being done in this area. So another molecule other than the CD33 for the monoclonal antibody, the other one is the anti-CD123. So this telecotuzumab is a monoclonal antibody against anti-CD123. 123 is an antigen that carries a poor prognosis in AML, and targeting this molecule is being tested in both newly diagnosed and relapsed refractory AML. Again, it is in a very initial stages. So we still have to wait for this data to more mature. This is an interesting molecule. This SL401 is a diphtheria toxin conjugated with IL-3 ligand. It was the first molecule that was approved for blastic plasmacytoid dendritic cell neoplasm in adult patients. Because of the success of this molecule and good tolerability, it was replicated in phase 1 trial in acute myeloid leukemia, wherein again it had shown some good responses. So coming to the checkpoint inhibitor therapy, the most important molecule, the most commonly used molecule again is PD1, programmed cell death 1, and cytotoxic T cell lymphocyte antigen 4 antigen. So these are the two molecules against antibodies are being developed, and these are essentially removing the brakes on the T cells so that they can be activated and be directed against the tumor cells. So ipilimumab and tremelimumab is the molecule that are being tested in various clinical trials. More so, they have been shown efficacy in the solid tumors than in liquid tumors, but wherever it has been used in acute myeloid leukemia, more benefit in post-transplant relapses as compared to newly diagnosed or other relapses has been shown. This molecule is being trying to be used in combination with PD-1 inhibitors. That data is still awaited, and the trial is still recruiting patients. The PD-1 is the most extensively checkpoint inhibitor that has been investigated, and it has been investigated. The trials are ongoing, but yeah, so it has been trying to be incorporated as a single agent as well as in combination therapy, mostly with hypomethylating agents, especially the azacitidine and destabine. It has shown some good responses, especially in patients with NRAS and ASXL1 and TP53 mutated AMLs. So in this sub-cohort of high-risk acute myeloid leukemias, this PD-1 inhibitor combination along with hypomethylating agent has shown some good and encouraging data. The toxicity profiles has been good enough to be used in clinical practice. So far, I think many of us, like most of us, would have not have used this combination, but this is what we're talking about in Hematology Express, that in the coming few years, that this is what we are going to practice. The other molecules, other antigens that are being targeted for checkpoint inhibition is the TIM3. The inhibitor used for that is sabotaliumab, and that is still in the very nascent stages of clinical trials. Coming to the CAR T cell therapy, we know that success story of CAR T cell therapy from Timothy et al. From very long, but the problem of replicating that success story in AML is mainly because of the synonymous antigens that are expressed on the acute myeloid leukemic cells as well as the normal myeloid cells. That's a challenge. But despite that, some of the molecules, some of the targets have been developed against which the CAR T cell in AML is being tested. The most commonly and successful stories that have been replicated so far is against the Lewis Y antigen and CLL1 antigen. The other antigens that are being looked upon aggressively is the NKG2 antigen and followed by CD123 and CD33 CAR T cells. So when the anti-Lewis Y CAR T cell was infused in 4 patients. So again, I'll just brief here that most of these patients have been relapsed refractory and failure of multiple lines treatment, and most of the time these CAR T cells have been combined with either chemotherapy or have been followed by chemotherapy regimens, and that is how they have been used. So in this case, for the anti-Lewis CAR T therapy, 4 patients, when they were infused, they had a sustained efficacy for more than 10 months post-infusion, and these were relapsed refractory high-risk AML patients. So if these patients can achieve a longer remission, that is something that probably sooner or later we might experience. There is a lot of CAR T buzz that is going in our surroundings as well. So there is some hope that CAR T therapy for AML might be available to us in the near future. The other antigen target is the CLL1 that is strongly expressed on the AML cells, but not on the normal stem cell. That's an ideal target category for this molecule. There are 10 relapsed refractory AML patients. They were infused with chemotherapy and CLL CAR T, and the CR rate was 70%. And most of the patients remained in CR for more than 6 months. So this is again a molecule that is being looked upon as an interesting molecule for CAR T target. NK2G2D ligand is a very interesting concept. So what is the concept behind this is that these ligands are weakly expressed on the myeloblasts and the chemo-resistant leukemic stem cells. And because of this downregulation, the NK-mediated killing is evaded by the tumor cells. So what is being targeted is, can we activate these silent NKG2D ligands, thereby directing the NKG2D CAR T cells against these molecules, so that ultimately the tumor kill can be achieved. So bispecific antibody system has been already designed, and still it is in the phase 1 data, and it's in the preclinical study. So it's in the preclinical study. The preclinical study in the AML cell lines has shown some efficacy for this approach. The CD123 and CD33, although they have shown good efficacy as a monoclonal antibody targets, but for CAR T cell therapy, they have not been very useful, mainly for the reason that these antigens are also expressed on the normal stem cells. So normal stem cells, and because of this, the side effect profile is more harmful as compared to the monoclonal antibodies. The last approach that I want to discuss here is dendritic cell vaccines. The benefit, as we discussed in the beginning, is that these vaccines are essentially monocyte derived stroke dendritic cell derived, and because of this they do not have the side effect of autoimmune side effects that other T cell directed responses the therapy elicit. So that is the advantage of these dendritic cell
Kindly conclude
vaccines.
your
So
talk in 2 minutes, please.
yeah, I'm just wrapping up. So dendritic cell vaccines have offered the potential of a non-toxic and an effective immunotherapy strategy. How these are produced, I'll skip that. So there are essentially three types of these vaccines. WT1 DC vaccine that has shown. So these type of vaccines have essentially been used as a prevention of relapse strategy. So like azacitidine used as a maintenance strategy. So something like that, cancer vaccines are being incorporated as in the treatment armamentarium for AML as a prevention of relapse strategy. So the most extensively studies, one of them is WT1 DC vaccine that has shown good responses. The other one is the human telomerase reverse transcripted DC vaccine. So this molecule, this vaccine is something that is being looked upon as the most promising so far, like with the whatever data is available today. And the last one is a DC AML fusion vaccine, and these are the interesting ones. So I think I'll come here to the end of the sort of talk, and to conclude, I would say just that the current clinical treatment options for AML definitely need some expansion. Redirecting patients' own immune system to fight aggressive AML is potentially effective weapon. Both humoral and cellular immunity can be harnessed, as we discussed in terms of monoclonal antibodies against CD33 and 123 in humoral immunity, and more importantly, the checkpoint inhibition that we are seeing as a new ray of hope for incorporating as a combination therapies in refractory AML. Appropriate algorithms and where these molecules have to be placed in the treatment algorithms, that is still not clear. We are still very nascent in that, and I think that will become more clear as the time evolves. So with this, I'll just come to an end and hand back to the organizers.
Yeah. So thank you, Dr. Meet. It's a very comprehensive and very good coverage of immuno-targeted therapies. Hardly personally, I have any experience. So any comments from Dr. Lalit sir, from your side, Dr. Lalit sir?
Thank you, Dr. Meet, for that comprehensive, lucid, and concise talk. He has covered all aspects of immunotherapy in AML very precisely. So I think we can move ahead towards the next talk. And I would like to invite Dr. Isha Kaul from Delhi. And she would be delivering a talk on novel therapeutic approaches in acute myeloid leukemia. Over to you, Dr. Isha Kaul.
Hello and a very good evening to everybody, and thank you very much to the organizers for inviting me for this wonderful session. So the topic that I've been given today is novel therapeutic approaches in AML. So since Dr. Meet was already going to speak about immunological approaches, immunotherapeutic approaches for AML, I decided to limit my session to non-immunological novel approaches in AML. So there were a lot of abstracts presented in EHA 2023, and I have chosen 5 which I felt were big impact and relevant for us to know. So I'll start with the abstracts that I've chosen. Can everybody see my slides?
Yeah, it's visible. Yeah.
Okay. Right. So the first major abstract which was presented was a study of azacitidine, venetoclax, and gilteritinib for patients with newly diagnosed FLT3 mutated AML. This was a subgroup analysis. We know that FLT3 mutated AML is a poor prognosis AML. All of us are familiar with this, and it's challenging to treat those patients. More and more hypomethylating agents along with a combination of venetoclax is becoming standard of care for older unfit patients. But the relapse rate even in this situation remains relatively high at 40 to 60%. So the idea behind the study was to see if adding a FLT3 inhibitor to the AZA-VEN backbone will improve on the response rates and long-term outcomes. So the efficacy endpoint was there, and the primary endpoint was CR and CR with incomplete count recovery. So this was a phase 2 study. So these were older patients who were unfit for intensive treatment. So a total of 30 patients were in the study. Median age was 71, as you can see, and even up to 86 years of age, patients have been taken in. Both ITD and TKD mutations were included, even though the majority were ITD. And all variants of cytogenetic abnormalities were additionally also present. So the treatment scheme was interesting. Azacitidine was given as a standard dose. When was given, planned to be given for days, and gilteritinib was given for continuous 28 days. However, a bone marrow examination was performed on day 14, and in case blasts were less than 5%, then both men and gilteritinib were stopped. After cycle 2, the dose of venetoclax was then limited to 7 days, and gilteritinib was given continuously. So this study went on till January 2023. The response rates were excellent, with 90% of the patients achieving CR. And if you include CR and CRI, the total response rate was 96%. So pretty much everybody had a CR except for one patient. And majority of patients actually had very low blast count at day 14. So, the best response had probably already come by day 14 in a lot of these patients. And a vast majority of patients who were in CR were in high quality CR, so they were MRD negative. So almost 90% patients were MRD negative, and by flow and an experimental tool for FLT3 MRD was also employed, and that was also negative. 40% of the patients went on to get a transplant. Eventually, some patients did relapse. Obviously, they did. But 43% of patients had ongoing responses after transplant. Interestingly, of the relapses, 2 of the relapses were FLT3 negative. So there were some other mechanisms. FLT3 continued to be suppressed by gilteritinib, but there must be some other mechanisms of relapse. Another interesting thing was that even in patients who did not end up getting a transplant, the overall survival, at least till the point that the study was reported, was pretty good. So whether patients are transplanted or, for whatever reasons they don't undergo a transplant, both populations seem to benefit from it. So clearly a very, very active regimen therapy for patients with FLT3 mutated AML. Continuing our journey for FLT3 inhibition, now we come to the second study, which the Morpho Trial, which studies the same drug, gilteritinib, but in a different setting. So this study was a phase 3 study, which is designed to evaluate the effectiveness of gilteritinib as post-transplant maintenance. So different scenario altogether. So large study, more than 300 patients, and it has a lot of aims. Even evaluating FLT3 PCR as a tool for MRD is one of the modes and one of the goals of the study. And whether a FLT3 inhibitor can prevent frank relapse when an MRD is detected, that's another goal of the study. However, so far we only have interim results from the study. We'll have to wait for full data. So the study scheme was for patients to receive either placebo or gilteritinib for 2 years post-transplant, and they started as soon as possible after engraftment, and then they regularly underwent bone marrow examination for MRD assessment at month 6, 12, 18, and 24. And a PCR NGS-based assay was also used for assessing MRD, and stratification was done by MRD as well. In this situation, however, gilteritinib does not appear to make a very big difference. As you can see here, that the probability of survival, overall survival, is not significantly different. The p-value does not achieve significance in both the groups. However, in the subset of patients positive pre-transplant, which you can see in the bottom half, the curves do separate. So overall, it's essentially a negative study. The gilteritinib maintenance post-transplant does not seem to make a very big survival advantage. However, if patients are going into transplant who were positive pre-transplant, those subset of patients perhaps have some survival benefit and relapse-free survival benefit with maintenance transplant. So that's the subset in which this is more pronounced. Continuing with the theme of FLT3 inhibition, so this is another study, the QI study, which studies the addition of quizartinib to standard induction However, the interesting thing about this study is that it is studying in patients who are FLT3 wild type, so FLT3 non-mutated. The Quasar study initially, which studied this in FLT3 mutated. However, there were interesting observations from trials of FLT3 inhibitors in previously in SORAL study where sorafenib was used, in which some activity was detected even in patients who were FLT3 wild type. So that is the question that this study was trying to answer, whether adding quizartinib to standard induction of an anthracycline and cytarabine improves outcomes. So this was a randomized phase 2 trial, FLT3 ITD wild type AML patients, standard induction, standard consolidation, and quizartinib was added in induction as well as consolidation and maintenance. So all three phases. That was the study design, and that's the study scheme of how this went. Idarubicin was what they chose in this study. And patients, if they were felt fit for transplant, that was at the discretion of the treating physician. They could be transplanted, and it was a 2:1 randomization. So the response rates did not seem to differ. So in both the arms, whether patients did get or did not get quizartinib, the response rates were about the same, 70%, 28%, around that range. However, there was a survival advantage in the arm that got quizartinib. So this is somewhat similar to, the Ratify study also, in which even though the remission rates were not better with the adding of midostaurin, the long-term survival was improved. So indirectly, one can extrapolate that in the patients who have responded, perhaps the depth of response is better, or the quality of response is better, which is translating into a survival benefit, even though initially the CR rates are not different. And you don't have to have a FLT3 mutation to derive benefit from addition of quizartinib. And it seems that it was pretty safe and no additional safety signals were identified. However, we'll have to wait for the full before this becomes standard of care, or giving FLT3 inhibitors to non-FLT3 mutated patients becomes standard of care. Okay, now coming to the fourth abstract. We've been using, azacitidine, venetoclax, HMA, venetoclax induction become standard of care for all older patients. But the question that is now beginning to be answered a little bit is whether the patients who, go on to transplant after these kinds of regimens, do they have the same kind of long-term survival as we are used to in patients who have a standard induction, including an anthracycline. So this study, they took patients from two different studies, the VIAL study, which was a phase 3 study of HMA and venetoclax, and an earlier phase 1 study. So patients were pooled from both the two studies, and the subset of patients who went on to get transplants were studied. So this was a total of 33 patients with a median age of 69 years. Out of the 33 patients, 21 received aza-ven induction and 12 received cytarabine venetoclax induction. 70% of the patients had de novo AML, and as you can see, performance status is scattered across ECOG 0, 1, and 2. We have a good number of ELN adverse risk category patients. 2 TP53 mutated patients are also there, and all patients are in CR, and most of the patients are MRD negative, but some patients were also taken into transplant with MRD positivity, around half of the patients. So in this population who had been induced with HMA and venetoclax and went on for transplant, the median overall survival after transplant was almost 30 months. So that's giving us a 69% 1-year survival post-transplant. So that's, pretty good as initial data. And the patients who were MRD negative before transplant had even better outcomes. So their overall survival was 76%. In adverse risk, ELN adverse risk, the survival was slightly low. 2 of the patients were TP53 mutated. 1 relapsed and died, and the other remains in remission and is alive till the day the abstract was presented. So the outcome, basically, I think the take-home message is that when in combination with AZA or DEC can lead to one, deep responses, which we know. And even for patients who are not fit for intensive conditioning, they can be taken for transplant with this kind of induction. And most patients are alive. Most of these patients are alive and they did well. There was another small study which was comparing similar, I did not include it here, but I'm just mentioning, which included patients who had received, older patients, 60 years of older, who went to transplant, some of whom had received intensive like 3+7 or similar kind of induction, and the other HMA-based induction. And the PRMs were fewer in patients who had received HMA than inductions. Perhaps, we can just hypothesize why that would be. Perhaps they had fewer infections, less mucosal damage for all of these reasons. So I think it's becoming clear that this can be, hypomethylating in blood venetoclax can be used as, to prepare patients for transplant who are not otherwise fit for induction therapy, as long as they achieve a good quality remission. So for the last study, switching to APML, so this was a very, very interesting, this was an oral presentation at EHA. This was presented from a group at University of Hong Kong. They proposed a study of all completely oral induction consolidation regimen for APML. So they're calling it the AAA regimen with oral ATO, Atra, and vitamin C, ascorbic acid. The oral arsenic trioxide, they've been the pioneers in this group. It was first formulated in Hong Kong, and it's been shown previously that the bioavailability of oral ATO is comparable to IV ATO. And there is some data from their group showing that ascorbic acid somehow potentiates the activity of ATO. So this regimen was used. So the dosing that was employed, which was newly diagnosed APL, the ATO dose was 10 milligram per day or 0.16 milligram per kilogram. Atra is the standard dose, and oral ascorbic acid is 1 gram per day or 15 milligram per kilogram per day. So pretty high doses. Daunorubicin was used in patients who had high risk disease and were younger than 65 years of age. And the consolidation was also similar, oral AAA, day 1 to 14 for 2 cycles, followed by maintenance day 1 to 14 every 8 weeks for 12 cycles. And the primary outcome was overall survival, relapse-free survival, and safety. And the secondary outcome was molecular response. So very, very,
Ma'am, kindly conclude your talk in 2 minutes, please.
Yes, I'm concluding. This is my final slide. So the 3-year overall survival, relapse survival was, 98%, 99% to that tune. No additional cardiotoxicity or hepatotoxicity signal was noted. As expected, there was some diffusion syndrome, which was managed with dexamethasone, but it's quite promising that an entirely oral induction and consolidation regimen is as effective as IV for patients with APML. So that was my final slide. With that, I'll conclude my presentation and hand it back to the organizers. Thank you very much.
Thank you so much, Dr. Isha, for walking us through the recently presented data on the novel therapeutic approaches in acute myeloid leukemia. And I'm not able to see any questions in the chat box, so probably we can go ahead with the next presentation for the evening. And the next presentation is by Dr. Amrita Ramaswamy from Gurugram. And the topic for the presentation is Evolving Concepts in Chronic Lymphocytic Leukemia, Optimizing Treatment Strategies and Patient Experiences. Over to you, Dr. Amrita.
Thank you, Dr. Lalit. And I thank the organizers for inviting me for this Hematology Express. So since the time allotted is very little, 15 minutes, so I'll start off with my presentation. So let me just share my screen. I hope my screen is visible.
Yes, ma'am.
So the topic that was given to me was evolving concepts in chronic lymphocytic leukemia, optimizing treatment strategies and patient experience. So all of us know that CLL is an incurable disease. With whatever therapies we have right now, it is still, somebody cannot be entirely cured of CLL. So it is an incurable disease, and we know that multiple therapies are available at this time point to us, even in India. And I would just like to talk a bit about the role of chemoimmunotherapy. Is chemoimmunotherapy still relevant in the treatment of CLL? What's the role of novel and targeted agents? And being an incurable disease, it is important that we know what to use first, what to use next. And sequencing of therapies, rational sequencing of therapies is very important, as it is in myeloma, where we have a whole lot of drugs available, but sequencing is very important. And ideal use of drugs is very important. Now, I'll start off my presentation saying that chemoimmunotherapy has no role in CLL. I would kind of rephrase this. Some of my colleagues may not agree with me, but chemoimmunotherapy, as we knew earlier, has a limited role in the management of CLL, given the data that we have from multiple phase 3 trials. Now, this E1912 is a phase 3 trial of 529 patients with treatment-naive CLL. These were younger patients. They received either ibrutinib with rituximab or they received FCR. They were fit enough to receive FCR. We can very well see that the progression-free survival was better with ibrutinib rituximab compared to FCR, and even the overall survival was improved if somebody received ibrutinib rituximab compared to FCR. Now, this was the overall group, but if you look at the individual subgroups, or if you did a subgroup analysis. Now, this was a study which excluded deletion 17p. So we have mutated IGHV, we have unmutated IGHV, but we do not have deletion 17p. Now, if you looked at the overall progression-free survival, as I earlier said, it was better with the arm that contained ibrutinib compared to the FCR arm. And even in IGHV mutated and unmutated, the arm with ibrutinib rituximab did better in terms of progression-free survival. And this was another trial. This was the A041202 trial. This was again a randomized trial in which they had 3 arms. One was ibrutinib monotherapy, one was ibrutinib and rituximab, and the third arm was the conventional chemoimmunotherapy arm, the bendamustine rituximab arm. These were the 3 arms in this particular phase 3 trial. And very clearly, we can see that the ibrutinib containing arms, ibrutinib monotherapy and the ibrutinib rituximab arm had better progression-free survival compared to the conventional chemoimmunotherapy arm. But if you compare the monotherapy versus the ibrutinib rituximab, there was no real significant difference in the progression-free survival. So I think with this trial data, it would be safe to say that instead of adding rituximab to ibrutinib in all patients of CLL, it is worthwhile doing ibrutinib monotherapy and reserving rituximab for a particular subset of patients. And by a particular subset of patients, the addition of rituximab to ibrutinib is found to be helpful when somebody has bulky disease, or when somebody has an autoimmune complication like an autoimmune hemolytic anemia, because the benefit of rituximab is better in this subset compared to ibrutinib monotherapy alone. Now, this is again, we were talking about the treatment naive setting earlier. Now, this is the relapsed refractory setting. Even in the relapsed refractory setting, it is very much clear that the use of a novel agent like venetoclax with rituximab had a better progression-free survival compared to conventional chemoimmunotherapy. The other arm was the traditional bendamustine rituximab arm. We can see that the arm that contained venetoclax had a median progression-free survival of 53.6 months, vis-a-vis 17 months only in somebody who had received bendamustine and rituximab. And even the overall survival is strikingly different. Now, this was again another trial. So multiple phase 3 trials, which are showing us data that a BTKI inhibitor or a venetoclax treated patient does better in terms of progression-free survival and compared to the conventional chemoimmunotherapy arm. Now, this was untreated CLL, elderly patients or younger patients with comorbidities. So they received acalabrutinib either as a single agent, or one arm received acalabrutinib with obinutuzumab, and the third arm was the conventional elderly unfit chemoimmunotherapy arm, which is the chlorambucil and obinutuzumab arm. We can see very well that the acalabrutinib containing arms did better than the chlorambucil obinutuzumab arms. And even in unmutated IGHV, all of us know that's a high risk. So again, the arms containing acalabrutinib did better compared to the chlorambucil obinutuzumab arm. So in the interest of time, this is again another trial which showed that venetoclax containing arm did better than the conventional chemoimmunotherapy arm. This was again the Sequoia trial. We do not have zanubrutinib in our country, but again the comparator arms were zanubrutinib and bendamustine rituximab. The progression-free survival was better with single agent zanubrutinib compared to bendamustine rituximab. So now the question comes to which therapy is the best initial therapy? The answer is there is no single best initial therapy. From whatever data that we have, we appear to be moving away from conventional chemoimmunotherapy. DR used to be the treatment offered to CLL patients when I was in AIMS. Deletion, 17p and all that was not looked for. This was 10 years back, but now we need to look at the genetic character of the disease. And if somebody is high risk, chemoimmunotherapy is out. So the answer to this question is there is no single best initial therapy. We need to take into account multiple factors when we decide what is the best initial therapy for a particular patient. Disease biology, the genetics of the disease is very important. That is what is the major determining factor. There's no point in giving chemoimmunotherapy to somebody who has a deletion 17p. And if somebody doesn't have high-risk disease, then again, we need to take into consideration the comorbidities in the patient, what the patient preferences, toxicity considerations, and what the available resources are. Now, this is just a table that points out with newer agents and with BTKIs and with venetoclax, we have such excellent progression-free survival outcomes in multiple trials. 92%, 96%, 87%, 78%, 74%, and 61%. That's for the older agent, which is ibrutinib. Now, if you come to the NCCN guidelines, if you look at patients without deletion 17p, younger patients, older patients, preferred regimens, if you see most of it, there is hardly any chemoimmunotherapy in the preferred regimens. It's a BTKI, either as a single agent or BTKI in combination with an anti-CD20 monoclonal antibody. Obviously, we do have venetoclax with obinutuzumab. Zanubrutinib, of course, we do not yet have it available in our country. All the chemoimmunotherapy regimens, they take a second precedence compared to the novel agents, compared to the BTKIs and to the BCL2 inhibitors. Now, this is again for deletion 17p. There's no chemoimmunotherapy here. So it's just ibrutinib or acalabrutinib in combination with a anti-CD20 monoclonal antibody. But then, having said this, we need to understand that these therapies, especially the BTKIs, they come with long-term toxicities. There is obviously the financial burden, and we need to take into consideration patient preferences, because even incorporating a novel agent like a BCL2 inhibitor, time-limited therapy is still possible. But with BTKIs, BTKIs are not what tyrosine kinase inhibitors are like in CML, giving us great responses as single agents. We know that the best possible response that we can achieve with a BTKI inhibitor in CLL is probably only a partial response. So these therapies are probably infinite, they're always infinite, they're always continuous. And managing adverse events of novel therapies is equally important when we start a novel agent for somebody with CLL. So very quickly, I'll go through these slides. So we see that the most common cause for ibrutinib discontinuation is toxicity, and the common toxicities which most of us would have seen in our clinical practice, atrial fibrillation, especially in elderly patients, and in somebody who has polypharmacy, is already having atrial fibrillation, is on an anticoagulant. These are the patients in whom using a BTKI inhibitor becomes tricky. Having said that, ibrutinib was earlier available to us, was the only BTKI that was earlier available to us. But with the inclusion or with the availability of acalabrutinib, I think we have seen less and less of atrial fibrillation and bleeding. And most of our elderly patients with CLL who are receiving multiple drugs and also having cardiac comorbidities are able to safely receive acalabrutinib. Now, atrial fibrillation and flutter is not an absolute indication to discontinue BTKI inhibitors. All of us know that people with atrial fibrillation, most of them are also on an anticoagulant. Now, this becomes a little problematic because we know that ibrutinib predisposes to bleeding. Hypertension is again a known side effect. Hemorrhage and bleeding, again, we do see in practice. We've seen patients coming with PR bleed, and something which is not touched upon is infections. We need to know that this is chronic therapy. We have seen patients with fungal pneumonia sometimes who have been receiving a BTKI inhibitor. Apart from that, viral infections, viral reactivations, rare cases of progressive multifocal leukoencephalopathy and PCP pneumonia have all been reported with chronic BTKI use. The second generation drug, which is acalabrutinib, has probably a better side effect profile. Does not have the cardiac toxicities and the bleeding toxicities as compared to ibrutinib. But having said that, ibrutinib has been the longest kid on the kid that has been on the block for the longest. And acalabrutinib, I think the safety data still needs to emerge from multiple trials. Now, venetoclax, all of us know that it has to be given in the conventional ramp-up dosing, and TLS is a problem. Now, coming to, we just spoke about how BTKIs and BCL2 inhibitors are taking over as first-line treatment options from conventional chemoimmunotherapy. Now, even in the relapsed refractory setting, obviously, these are the drugs which kind of figure in the preferred regimens. But sometimes if somebody has had a good response to has had a good response to chemoimmunotherapy, rechallenge with chemoimmunotherapy can also be tried in the relapsed refractory setting. Now coming to, this is just a slide which shows that, chemoimmunotherapy is being sidelined. We have enough data that venetoclax does better in somebody who has been BTKI exposed and who has relapsed on a BTKI inhibitor. But now we also have data from some trials saying that the reverse may be true. Somebody who has received venetoclax upfront may respond or will probably respond to a BTKI inhibitor at relapse. Now, this is again a slide. This is the ESMO clinical
kindly
practice.
conclude your talk in 2 minutes, please.
Yeah, so let me just finish with this slide. I actually wanted to cover a bit of EHA, the latest things that are coming, but I think for the want of time, I'll just wind up here. So I would just conclude by saying that chemoimmunotherapy has a limited role in the treatment of CLL. Probably the only patients in whom we would offer chemoimmunotherapy upfront are patients who do not have a TP53 mutation or deletion 17p and who have an IGHV mutated profile. And if this patient is fit, we can see that FCR figures over ibrutinib. You could still get away with offering FCR to this patient. And if it was an unfit patient, you could do chlorambucil, obinutuzumab, or probably even bendamustine rituximab. Whereas if you see in the IGHV unmutated and also in the TP53, it is the gluten tyrosine kinase inhibitors and the venetoclax with a monoclonal antibody that is ruling the roost. And we also have data concerning the usage of ibrutinib and venetoclax together, which can give a deeper response. For the want of time, I'm not covering that. So I'll just conclude with this slide that the paradigm of treatment of CLL is changing. We are moving away from chemoimmunotherapy to the BCR inhibitors. The goal of therapy obviously is disease control. We may not be able to get the deep responses that we get with chemoimmunotherapy, especially when we use BTKIs. Venetoclax can still put us into a very, very deep response. The treatment with BTKIs unfortunately is a continuous treatment, so long-term toxicities needs to be managed. Sustained PR is the best response, but we have excellent progression-free survivals with BTKIs. So as the patient becomes less fitter and as the patient has a poor risk genetic profile, we are moving away from chemoimmunotherapy towards the BCR inhibitors, the BTKIs and venetoclax containing regimens. So I'll just conclude here, and I'll thank the sponsors for this opportunity again.
Thank you, Dr. Amrita, for that wonderfully lucid and concise talk on the vast topic of evolving concepts in CLL. I would request Dr. Ashish Verma, my co-chair, to kindly deliver the concluding remarks for this particular session.
So, Dr. Amrita, just I have a personal question. Actually, I recently encountered.
I cannot hear you properly. Just a minute.
Yeah.
Can you say repeat your question again?
Yeah. Am I audible, Dr. Amrita? Am I audible? Yeah. So recently, I encountered this CLL patient. Actually, CLL patient was on ibrutinib. He's an old guy, 70 plus, came with a severely anemic, almost hemoglobin of 5. So on evaluation, found to have a DCT positive.
Dr. Ashish, I can't hear you. Your voice is a bit mumbled, actually.
Okay. So yeah.
Hello? So I just heard a 72-year-old on ibrutinib.
Yeah. Came with a severe anemia of hemoglobin 5. On evaluation, found to have a DCT positive. So we are planning to give rituximab along with steroid. So what will be the plan of rituximab in this case? Means we have to give any weekly or monthly regime because of underlying CLL. What is your comment?
See, the trial which I presented, in which ibrutinib was monotherapy, there was an arm which contained ibrutinib and rituximab, and then there was I think bendamustine rituximab arm. So it was very clear that adding rituximab to ibrutinib did not really translate to a better progression-free survival. So rituximab is particularly reserved for those patients who have very bulky disease, because we know that ibrutinib is going to cause initial lymphocytosis and is initially going to have problems. So when you want to rapidly debulk somebody, addition of rituximab to a BTKI inhibitor to ibrutinib makes sense. And if somebody had an autoimmune complication, somebody presented with an autoimmune hemolytic anemia, and you want quick disease control, the addition of rituximab, we use rituximab in AIHA even if somebody does not have CLL. So that's the benefit of adding rituximab in somebody who has an autoimmune complication. If you do choose to treat them with ibrutinib instead of ibrutinib monotherapy, in this subset of patients who probably you want to debulk quicker, or who probably present with an autoimmune complication, refractory to steroids, maybe AIHA refractory to steroids, you want to treat them with ibrutinib, then you would probably add rituximab to the ibrutinib backbone.
And it has to be given in weekly regime, I think, preferably to get the faster response for AIHA per se. The rituximab has to be given in weekly regime. Weekly, am I audible? No. Okay.
You're very feeble, actually.
Okay. So it's a very
So Dr. Ashish, initially weekly for 4 weeks, then monthly for another 5 months can be a better option. We are giving rituximab to such patients where you are having autoimmune phenomenon.
Okay. Thank you.
So I'm thankful to our speakers, Dr. Amita Ramaswamy, Dr. Isha Kaul, Dr. Meet Kumar. I'm also thankful to our chairperson, Dr. Ashish and Dr. Lalit Sharma. for chairing this session. For the next session, I will invite our chairperson, Dr. Mohan Sharma sir. He is associate professor at Mahatma Gandhi Medical College, Jaipur. I also invite Dr. Umesh Khandelwal. He's a senior consultant medical oncologist at Santoba Durlaji Medical Hospital, Jaipur. Over to you, chairperson, for the next session.
So thank you so much, Dr. Upendra, for your kind invite, and extremely happy to see the extremely good quality presentation. Dr. Amrita has covered very well about the CLL aspects, and that's a great learning. So from leukemia, now we switch over to the lymphoma part, and we will have 3 sessions in that. One will be about the DLBCL current management. Other, we will be having a relapsed refractory disease, and third will be case-based panel discussion. So without wasting much time, may I invite Dr. Sachin from Bangalore to deliver the first talk on how should we treat the DLBCL in the first line setting. Over to you, Dr. Sachin.
Hello.
Yeah, good evening to you, sir. Dr. Sachin. We can see you very well. We can hear you, and we have the slides with us. Over to you, please.
Thank you. Can you see my slides?
Yes, sir.
Yes, your slides are visible.
Can you see my slides now? Okay, thank you. So, thank you so much, Dr. Upendra. Invite this talk. It's a pleasure. I'll be talking about a very simple, basic topic, something that we manage on a daily basis in our clinic, as to how do we treat diffuse B-cell lymphoma when they are first diagnosed. We will not be dealing with the relapse refractory patients. We will only look at the routine approach to treatment, as well as some few nuances of clinical conditions. So we are all aware that DLBCL is the most common B-cell non-Hodgkin lymphoma, and about at least 20 to 30% of our patients of lymphoma are. Incidence of this disease increases with age, and which causes some challenges, because we see quite a few patients in the 50s and 60s, and in the West, seeing patients over 70s and 80s even more common. It's an aggressive disease, which means that evaluation and treatment, but at this time, it is potentially curable in the majority of patients. What we mean by curable is a lot of patients, rather most of our patients will get cured and will not have a relapse with just the first bunch of treatment, whatever chemo immunotherapy that we choose. And even if the relapse, a significant percentage of the relapse refractory patients will also see long-term remissions or cure. And this has improved over the decade since we have added rituximab as an immunotherapy agent to the backbone chemo of CHOP, which was given almost exclusively either CHOP or CBP about 20 years ago. However, with the addition of rituximab year on year, rather decade on decade, we have seen improvement in outcomes. Things have also improved because we have realized how to give better supportive care and pull patients out of potentially life-threatening complications. The current standard of chemo that we consider for every patient is R-CHOP, that is rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisolone, whatever stage of the disease it is. Now, this undergoes some change based on the general condition of the patient. So, for example, if they have a cardiac dysfunction, then we like to change the anthracycline to etoposide. And in patients who are older, we might tone down the intensity of the chemo. However, the backbone of treatment today still remains R-CHOP. Until a few years ago, we would only give 6 cycles of R-CHOP, sometimes with consolidative radiation, and then stop. However, there is an increasing amount of data that in the older patients, giving lenalidomide maintenance might help. There is another problem with diffuse large B-cell lymphoma, that this being aggressive lymphoid malignancy, that some patients will have a CNS relapse. Although this is not as common as in ALL, however, about 4 to 5% of patients have been shown to have a central nervous system relapse. And thus various attempts have been made to reduce CNS relapse. People have tried giving intrathecal methotrexate or intrathecal cytarabine. People have tried giving high-dose methotrexate up to 3 grams per meter square, 2 or 3 cycles, either at the end of R-CHOP or intercalated between R-CHOP. And there is, varying smattering of data. Almost every 6 to 12 months, a new paper comes up, which again questions whatever our concepts and our pattern of thinking is. However, most of us assess the risk of CNS relapse in every patient, typically using a scoring system such as the CI course. We would consider giving prophylaxis, CNS prophylaxis. Having said that, in our practice, we are not very keen on it. Primarily because people who fall in high CNS IPI are often older, they are frail. We have tried giving high-dose methotrexate in patients, but they don't tolerate. We've in fact lost one patient due to neutropenic sepsis because of high-dose methotrexate. We don't give intrathecal methotrexate because there is more and more data that it doesn't really help. So I don't really know what to do. Every time we see a patient who has high CNS IPA, we consider this, but more often than not, at least in our department, we are not going for MTX. However, I'm aware that some oncologists and hematologists do practice this routinely. So if we look at NCCN, when a patient is first diagnosed, we see whether they are stage 1, 2. This is standard Ann Arbor staging, typically with PET-CT nowadays. And in stage 2, whether they have extensive mesenteric disease or they have advanced stages such as stage 3, stage 4. In lower stages, stage 1, 2, without extensive mesenteric disease, if it is non-bulky disease, 3 cycles R-CHOP, do a PET-CT, and then follow up with 3 more cycles of R-CHOP, depending on what the interim PET-CT shows. In those who have bulky disease, we give R-CHOP and follow it up with an involved site radiotherapy. In advanced disease, we kind of give the same chemo, but we may choose to escalate the treatment after interim or end of treatment PET-CT. So if the interim PET-CT shows that, especially in early disease, 3 cycles itself, the 5-point scoring system is 1 to 3, then we may just give total 4 cycles with or without ISRT and stop. However, in those who have some PET-POTS positivity in the interim PET-CT, we like to complete a total of 6 cycles with or without radiation and then stop treatment. Of course, at any point during interim PET, if there is insufficient response, or at the end of treatment, the PET-CT shows that there is insufficient response, indicating that it is refractory disease, or in some patients there is progressive disease in spite of R-CHOP, then we treat the patient as a relapsed refractory patient, where we typically give a higher intensity chemo followed by an autologous peripheral blood stem cell transplant. Stage 1 to bulky disease, the goal after of chemo is ISRT. Various radiation oncologists try different intensities of radiation. However, for the large part, the outcomes are good with this. I've already spoken about this. Now coming to some specific scenarios after this overview of treatment of DLBCL NOS, not otherwise specified, I'll be looking at certain key clinical scenarios. One of these that we have all been talking about and discussing since the Hans algorithm was published, I think about 15 years ago, is an entity called double expressor lymphoma, which means there is MYC BCL2 or MYC BCL2 BCL6 expression, overexpression with immunohistochemistry. Whenever we see a double expressor, that means MYC BCL2 with or without BCL6 is overexpressed in IHC, in the lymph node biopsy, we tend to do a FISH for these same genes. And if there is any rearrangement, if there is FISH positivity of c-MYC BCL2 BCL6, then the patient gets categorized as double or triple hit lymphoma. So expressor is one level and hit is where the FISH is actually positive. Now these patients have been shown to have a poorer prognosis. And there is now long-term data. You can see this data is almost over 10 years, showing that patients continue to relapse. If you look at the blue curve, that is a non-double hit, versus the gray curve, which is a double hit, the relapse in the double triple hit lymphoma is very rapid, usually within the first 1 to 2 years, and cure rates are practically 10% or less.
Sir,
These are the, sorry?
kindly
Hello?
conclude your talk in 2 minutes, please.
Oh, okay. All right. Sorry. So there is a case made towards therapy intensification, but we are not very sure. Even the ASTCT guidelines do not say that doing an upfront autologous transplant helps in these patients. There are, of course, a lot of novel therapies which are being tried. And other than polatuzumab, none have been are currently recommended in first line. A unique subset of DLBCL in the elderly, and these patients again have a poorer outcome because they do not have a good general condition, and some of them may not even receive treatment. So typically they receive R-CHOP, R-CVP, R-COP, or even R-mini-CHOP more often because a physician may feel that only that can be tolerated. As the age increases, the outcomes get worse, and there are some newer regimens such as ibrutinib, rituximab, lenalidomide, all those small studies which can be tried. We give very intensive support care for the elderly. And that's how we treat. There are, of course, other special situations in DLBCL. We won't go through these in detail, but that's my presentation. Thank you.
So thank you, Dr. Sachin, for such a lucid presentation. Any questions? And otherwise, I request Dr. Umesh Khandelwal sir to invite the next speaker. Any questions for Dr. Sachin? Great, thank you. So Dr. Sachin, we also will request you to stay back for a panel discussion if you are okay with this. Dr. Umesh Khandelwal, can we request you to invite the next speaker? Okay, so because of the paucity of time, let me take this liberty to invite the next speaker, Dr. Shruti Toshiwal. Good evening to you, ma'am. And Dr. Shruti she's a hemato-oncology consultant at Aurangabad, and ma'am will be giving a talk on how can durable remissions be achieved in patients with relapsed refractory DLBCL. So once again, very good evening, ma'am. Over to you for your presentation.
Good evening, everybody. Can you share my slides or should I share?
Are you okay? If you are okay, you can share your slide. Just
yeah,
try.
I can
Otherwise,
share. Yes.
Please, ma'am.
So,
ma'am, you have ma'am, it seems like you have a weak bandwidth. So if you can just stop your video and then you can start your presentation. Make it full screen and then you can start.
Okay, just So is it okay now?
Yes, it is much
Can
better.
you hear? Yes, yes.
Yeah, we
Yes.
can hear.
Thank you, Upendra Sharma sir. Yeah, thank you, Upendra Sharma sir, and thank you, team, for giving me this opportunity to present this topic. So this is a very not very easy topic, I may say, and not many drugs are available. Still, we can go in details how we can achieve a durable remission in relapsed refractory DLBCL. So this is the overview of relapsed refractory DLBCL. Like, this is the thing what we are going to see in the next few slides. What are the
Sorry,
treatment options?
can you go to the next slide, because I think आपका next slide नहीं आया. Can you go to the next slide?
I can see the next slide, but I don't know why I cannot see.
Okay.
Maybe
No.
if you can put it on
Yes.
from your
Okay,
side.
ma'am. Okay. Sure. So, Abhimanyu, can you just share the slide for ma'am, please? Ma'am, if you could just stop sharing your screen, my colleague will share for you, and
Yes,
then you
yes.
can say next
Okay.
slide, next
Yes,
slide.
Yes.
Abhimanyu, can you share the slides for Dr. Toshiwal, ma'am?
Sure, sir.
Yeah.
Yes. Thank you.
Come to the slide number 2 and make it full screen.
Yes.
Over to you, ma'am.
Yes, thank you. Thanks a lot. So this is, I'll just touch in a brief in the epidemiology. 55 to 60% of the DLBCL, as sir said, are alive and at 5 years and cured with modern therapy, but 10 to 15% patients are refractory to first-line therapy, and additional 20 to 30% relapse after a complete response. And the patients who have an early relapse, like within 3 to 6 months of the initial therapy, less than 12 months of the initial therapy, or they have a primary refractory, which is have the worst outcome even with whatever current available therapies we have with us. Next slide, please. Next slide, please. So we will discuss the predictors of poor outcome in DLBCL. So poor outcomes is the double hit lymphomas, the ultra high risk features where there is high intermediate to high IPI, where there is LDH is high, and all those are the risk factors for the poor outcome and risk factor for being primary refractory or early relapse. So this is the flowchart which we are going to discuss. So next slide, please. So whenever we have a patient who relapses, say within first 12 months, we first see that whether the patient is fit for transplant or unfit for transplant. If the patient is fit for transplant, then we evaluate whether patient is primary refractory or patient is having an early relapse. And then we see if we have the facility for a CAR-T therapy. If we have a facility for the CAR-T therapy, we can straight away go for a CAR-T therapy with plus or minus bridging therapy. If we don't have access to CAR-T therapy, we'll try salvage chemotherapy. If there is CR or PR, we can, if CR, better outcomes with autologous stem cell transplant. If PR, we'll think about again CAR-T therapy or autologous stem cell transplant with their limited outcome. And if the patient is unfit, then again we see if there is access to CAR-T, or we have newer drugs in the pipeline like anti-CD19. There are a few antibody drug conjugates combinations, and there are various novel drugs which we can try in the third line plus. So this all we'll discuss in the upcoming slides. Next slide, please. So shortly, I'll brief about autologous stem cell transplant, because that is the standard of care at present in our country at least. So, but autologous stem cell transplant, whatever trials we had previously, have shown that they have increased the outcomes in relapsed refractory patients before the rituximab era, in the rituximab era. Next slide, please. Next slide. So, but I want to highlight one point here. In spite of having a good outcome with autologous stem cell transplant, still our patients don't do as good as if they are ultra high risk features, like they are early relapse, they are refractory to primary therapy, if they are double hit or double expressor, they have primary progressive disease. So this study, what they have seen, in nearly 300 patients with ultra high risk feature and 2-year OS with no ultra high risk feature is as good as 74%, and with 2 or 3 this ultra high risk feature is as low as 10.7%. So what we have to, like, we should have some better treatment regimens for those ultra high risk patients. And this is the same study which they have seen that the refractory DLBCL autologous stem cell transplant will not achieve as good outcome as the patient are late relapses or they respond to the salvage chemotherapy. So what options do we have for those patients here? Next slide, please. So what is the game changer in such cohort? So the game changer in that cohort where there is a early refractory disease or a early relapse, it is a CAR-T therapy. And primarily we have 2 CARs which have been approved for the therapy of DLBCL. Next slide, please. So this CAR-T overview, we all know that whatever CAR-T we have for DLBCL is a second generation CAR-T which is having a co-stimulatory domain, axi-cell having CD28 and PISA cell and lyso cell having 4-1BB co-stimulatory domain. Also, we know that there is a time gap when we advise a CAR-T therapy and we get a CAR-T therapy, there is a time gap in between. So because we want that time gap for the CAR-T modifications and expansion before we have an infusion. So next slide, please. So whatever we discussed, we have these 3 CAR, but 2 are only approved at present. This axi-cell and PISA cell, these 2 are approved for the second line therapy in early refractory or early relapse patients. So I'll discuss in short about all the 3 CARs, the trials in this 3 CAR therapy, and a short outcome with this CAR therapy. Next slide, please. So this is a new paradigm shift in the treatment of relapsed refractory DLBCL. So there are the 3 pivotal phase 3 trials, which is ZUMA-7, axi-cell, Transform, which is PISA cell, and Belinda, which is lyso cell. And then axi-cell and lyso cell has been approved for fit patients with primary refractory and early relapse large cell lymphoma for the second line therapy in 2022. Next slide, please. Next slide, please. So, is there any role of bridging therapy prior to CAR? So, we can have a lot of bridging options. Few trials had allowed bridging options, few trials had not allowed bridging options. But whatever we can just take out of all the trials is that if it reduces disease bulk prior to CAR, it prevents organ dysfunction in the waiting period, reduces the chances of CRS and ICANS after the CAR-T therapy, and also if the CAR-T therapy is given in patients with CR, if we have a long bridging, we'll have a long waiting period till we get a CAR, and we give a bridging therapy, and patients have a more than CR or a CR, then those patients, even with ultra high risk, have very, very much better outcome with CAR-T therapy as compared to patients whom we take the CAR-T in active disease. Next slide, please. So these trials, just skip 2 slides. I have a table where I compare all the 3 trials. So in we have a little time crunch. So I'll just brief all the 3 trials in one slide only. Please change the slide. Next slide. Next slide. So this. So we have these 3 trials. This is a ZUMA-7, which is axi-cell, Transform, which is lyso cell versus the best available therapy for this patient. So this therapy where patients were also having received transplant also as a second best line of therapy. In the ZUMA-7 trial, what the median event-free survival was 8.3 months in the CAR-T compared to 2 months, and overall response was 83% compared to 50%, and the CR rate was 65% compared to 32% compared to the best available therapy, which all led to the approval of axi-cell in the second line in this cohort. Also, similar results with lyso cell. Lysocell, but unfortunately in the Belinda trial with Tisacell, we couldn't have those results. So at present, Tisacell is not approved for the second line therapy, and Axicell and Lysocell which are approved, and they have very good response in this very refractory subset of patients. Next slide, please. So what we are doing in India. So in India, we have a human phase 1 clinical trial which was done with IIT Bombay and Tata Hospital. So they had anti-CD19 CAR-T which was locally available, locally made and accessible and affordable. So they had 14 patients, out of which 10 received this CAR-T therapy. So the median follow-up of around 4.5 months. 3 had a complete response, 1 had a partial response, 1 had a stable disease, 3 had disease progression. And the CRS rates and the ICANS rates were very, very less compared to the world data. So there were no ICANS events, and it was very well given within a span of almost 7 days. Hello? I'm audible.
Yes, ma'am.
I'm audible, no? Yes.
Yes, ma'am.
Yes. Yes. Okay. Next slide, please. Go to the next slide, please. Yes. So also these are available in the third line and later with all these trials. I'll not go in details with these trials, but just I want to point out this patients are doing very well on those therapies. What do we have for unfit patient with relapsed refractory DLB? So not fit for CAR-T or not fit for autologous stem cell transplant. So we have a big list of drugs. So I'm going to discuss the game changers in this setting. Next slide, please. So the next drug which I'm going to discuss is tafasitamab plus lenalidomide, which is an anti-CD19 monoclonal antibody. Next slide, please. So this image gives an overview of all the therapies what we have for DLBCL, including tafasitamab, the bispecific antibodies, the polatuzumab, the small molecules which have a downstream effect like ibrutinib, copalanib, and various other drugs. Next slide, please. So, this tafasitamab plus lenalidomide in relapsed refractory DLBCL. This trial, maximum patients were about 50% of the patient had high risk features, and they have like whatever response they have shown in this trial are excellent, which the median duration of response where patient have achieved PR is 5.6 months, but CR it is not yet achieved. Median PFS in patients with achieving CR are not yet achieved, and the overall response also with CR is not yet achieved. So this is a very good drug in this setting with a median PFS of 11.6 months and median OS of 33 months. Next slide, please. So when we compare this with whatever available therapies, also these have shown that this drug is doing very well compared to what we have BR, what we have RGMOX, and other systemic therapies pulled together, and which was statistically significant. And median time to next therapy in this cohort was 12.5 months compared to 6.3 months in other therapies. The median overall survival was 34 months compared to 11 months, and median PFS was 12 months compared to 5.5 months, which was all statistically significant. Next slide, please. But comparing previous slide.
Kindly conclude your talk in 2 minutes, please.
Yes. Just move on to the further slides. So in conclusion, this has a clinically significant durable response in relapsed refractory DLBCL who are not eligible for autologous stem cell transplant. And next slide. So we have other drugs which are antibody drug conjugates, which is a very important, like sir discussed about polatuzumab in the upfront setting, polatuzumab plus BR in the relapsed refractory setting compared, next slide please, compared to BR is also, next slide. So polatuzumab plus BR compared to BR is also doing very well with 9.2 months of median PFS compared to the 3.7 months. These we consider in non-transplant, non-CAR T therapy patients as a bridging therapy to CAR T, post-CAR T failure. Next slide, please. Again, we have this CD19 antibody drug conjugate, locanciximab, which I'm not going to discuss in detail. Next slide, please. Selinexor is also a good drug, but a lot of GI toxicity. Next slide. So beyond this, whatever we have upcoming BiTEs, which are changing the treatment shift, and we have a lot of new drugs upcoming. Next slide. So these are the few comparisons. Among this, epcoritamab is showing very excellent results in this relapsed refractory, non-transplant eligible, this patients. Next slide. Next slide. So if we, like, whatever agents we have at present, like ibrutinib, we have lenalidomide, we have venetoclax plus some combinations. So among this, lenalidomide is a very well used drug, and with non-GCB DLBCL, it's having an overall response of 28%. Ibrutinib with ABC DLBCL is having an overall response. So when I summarize, this is my whatever we discussed. So this graph summarizes the in relapse refractory, early relapses refractory, CAR T is the answer to our questions. And next slide, please. Next slide. So my take-home messages are that CAR T has revolutionized. Tafasitamab plus lenalidomide is also a very excellent combination in a relapsed refractory non-transplant eligible patients. Various BiTEs are coming up, and Indian phase 1 data on anti-CD19 CAR is also very supportive. So we can have, next slide. So we can have hope, and hope lies in dreams, in imagination, and in the courage of who's there to make dreams into reality. So this is what is changing the paradigm in relapsed refractory DLBCL. Thank you. And I thank every sir for giving me this opportunity to present this topic.
Thank you, Dr. Shruti, for that wonderful talk on relapsed refractory DLBCL. I am also thankful to Dr. Sachin for his excellent talk on DLBCL in the first-line setting. Now I invite Dr. Rahul Nathani to moderate a panel discussion. He is Director Head, Department of Hematology and Bone Marrow Transplant at Paras Hospital, Gurgaon. Dr. Rahul Nathani, please introduce your panelist.
Good evening, everyone. Thank you, organizers, for giving us this opportunity to discuss this important topic, which is, very dynamic in today's time. Rapidly, new data are coming in. I think I'm having some issues sharing my slides. If someone from the organizing side could share it.
Yes, sir. So Nishant will share the slides. Sir, you have the esteemed panelists. Dr. Lingaraj Naik is there. Dr. Ashish Verma is there. Dr. Sanjeev Yadav is there, and Dr. Aviti Bavija is there.
Right.
So you can always involve Dr. Shruti, madam, and Dr. Sachin.
Yeah.
So make it full screen, please. So, Nishant. Slide showing down. Yeah. So can you see the screen, please? Oh.
Yes, I can see. Next slide, please. So these are our expert panelists. They have been introduced. Dr. Ashish Verma from Jaipur, Dr. Aviti Bavija from Dehradun, Dr. Lingaraj Naik from Mumbai, Dr. Pooja Prasad from Mohali. She communicated that her net signals may be intermittent. Dr. Pratibha Dhiman from Delhi, and Dr. Sanjeev Yadav from Lucknow. Next slide, please. So we all understand that outcomes for diffuse large B-cell lymphoma, which we generally counsel patients, that's a good lymphoma to have. About 60 to 65% patients are going to be cured with the upfront therapy. However, 15% patients are going to be primary refractory, and 20 to 25% are going to relapse after this. Now, if you look at the Kaplan-Meier and the median months mentioned there, if you are primary refractory, your median survival was 7.1 months. If you are refractory to second line or later line therapies, the median survival was 6.1 months. And if you have relapsed less than a year of autologous transplant, then the median survival was about 6.2 months. Next slide, please. So my question to my panelists, I can ask Dr. Lingraj Nayak first. How do you define refractory DLBCL, and how do you differentiate in terms of timeline between early and late relapses?
Hi. So thank you for that question. So I think refractory DLBCL is when we have when you say that it is primary refractory, when the patients do progress on ongoing treatment. That is when you do an interim scan, or and when there is a clinical progression. Now, relapse typically, when we define, we say that they have a response, like they attain a CR, and then there is a relapse. And that early versus late, when we say that, typically we take it as 12 months from the treatment completion. So if the patients who are in CR and within 12 months they relapse, that is typically taken as early relapse. And those who relapse after 12 months is something which is called as late relapse.
Yeah. Next slide, please. So yes, a refractory DLBCL, as Dr. Nayak has rightly pointed out, if patient has just not responded or relapse within 6 weeks to 3 months is taken as primary refractory, and the relapse or less than 1 year is taken as an early relapse. Next slide, please. Dr. Pooja, if you have been able to join, could you tell how do you define rituximab resistance in your clinical practice? I think she may not be available. I can pass this on to Dr. Ashish Verma.
So rituximab resistance, am I audible, sir?
Yes.
Yeah. So if patient is not responding with the first line treatment that we usually give R-CHOP, or patient is progressing on treatment, so we can say it's a rituximab resistance, sir.
Next slide, please. So again, as has been pointed out, rituximab resistance, if you are on a rituximab based therapy, now sometimes it's difficult to differentiate whether it was a resistance to rituximab or one of the components of CHOP. But if over disease progression while on this therapy, insufficient response or progression within 6 months of the last dose of rituximab, these are taken as the clinical signs of rituximab resistance. And it is presumed that significant proportion of patients with relapse or refractory DLBCL, they are resistant to rituximab. Next slide, please. Now, I think this has been already covered by the previous two speakers, the general evolution of relapsed refractory DLBCL treatment. Next slide, please. So if I can ask Dr. Dhiman, what is your first line salvage therapy when a patient with DLBCL has relapsed, and do you differentiate if the patient was young or old, or basically good performance status versus an infirm patient? Dr. Dhiman, you're there? I think we are not able to hear. I'll pass this question to Dr. Professor Sanjeev Yadav.
Hi, sir. Good evening.
Good evening.
For salvage therapy, usually we have option of RIs, RDAP, or RGDP. According to our preference, we use any of the 3 salvage regimen. But with the availability of CAR T-cell therapy in some centers, definitely it will be emerge as the first line salvage therapy in some centers, and in future in other centers also.
So at SGPGI, what is the first line? What is the first therapy that comes to mind in a relapsed DLBCL?
Usually we use RIs or RDAP.
Next slide, please. So as Dr. Yadav has already pointed out, you have RDHAP, you have RICE, you have RGTP, ESHAP, several other combinations, GEMOX, MIND you could use, and in early relapses now where available, even the CAR T cell therapies are coming in. Next slide, please. However, there was a network meta-analysis done which compared different kinds of salvage regime. And it basically included, one of the analysis included 1831 patients, 6 trials with 7 regime. And they found that RGTP based regime, which is our center's first choice in relapse DLBCL, that improved OS and PFS compared to the other salvage regime. However, the guidelines are still, they do not point towards one particular regime. They said you could use either of them. Similarly, the network meta-analysis of the 3 CAR T cell trial, we know one of the CAR T cell trial had failed, the Belinda had failed, but Axicell and Lisocell, they improved PFS over a standard of care with no difference in overall survival. Next slide, please. Dr. Avriti, are you there?
Yes, sir.
So how do you sequence therapy in a relapsed diffuse large B-cell lymphoma? And I'll request organizer, please move on to the next slide.
So currently, since we don't have an option of CAR T cell therapy, so first of all, we try with the conventional, if the patient is fit, or in fit patients, we'll give the salvage therapy and we'll go for the autologous stem cell transplant. And for the unfit patient, if the patient has been refractory to the first-line therapy, first-line salvage therapy, in that case, we may go for trying other. At current scenario, we'll enroll the patient in clinical trials and then we'll give the therapy accordingly.
So as is rightly pointed out, we talk about modern science, but in clinical practice, we are limited, first of all, by the availability of the CAR T itself, and then there are financial issues. However, if we go by the science, the FDA-approved therapies are, again, the CAR T cell therapy for early relapses less than 1 year. And then we have, tafasitamab and lenalidomide combination. Similarly, we have another humanized, anti-CD19 antibody, which has been recently approved. And then we have antibody drug conjugates like polatuzumab, bendamustine, rituximab. Now, polatuzumab is available in India. Now, this is also one of the approved drugs which shows in terms of the clinical practice statistically superior survivals. Next slide, please. Now, if historically, if somebody, who was transplant ineligible and had relapsed refractory DLBCL, you salvage with either BR or R-GEMOX kind of regimes, and the median survivals, the 5-year survivals were, 10%, 13%, and the median PFS used to about 6.5 months kind of thing. Next slide, please. Now, this scenario is changing even in India. Next slide. Where now polatuzumab is available, and it is already approved that polatuzumab can be used in combination with bendamustine rituximab, and it does show improved survival outcomes. Next slide. So polatuzumab is one drug which is now available to us. This is how Dr. Baweja had tried to answer this question. How do we sequence therapy? You basically see when someone is relapsing, if somebody is relapsing within an year, and if he's a candidate for CAR T, then we should offer CAR T. However, we need to realize that once a patient has relapsed, we talk about all this. Patients who are eligible for transplant eventually would undergo transplant. You are able to cure only 5% of this whole population. And for CAR T and are able to get it, you are still able to cure only 20%. So there are 75% patients who, despite these CAR Ts and despite autologous transplant, will not have another option. And that's where the newer molecules like polatuzumab, selinexor, these molecules come into picture. Next slide, please. And we know that CAR T cells now have been pushed forward into the second line, or they were approved for the third line. And we know that Axicell and Lisocell had a superior PFS survivals. However, TISA cell had failed. Next slide. So, Dr. Nayak, with this fantastic data coming out for CAR T trials, is it going to replace autologous transplant when freely available?
Yeah, so I think in early relapse, it has replaced, but the question is late relapse. And in late relapse, still autologous transplant is standard of care. When I say late, it is more than 12 months from the treatment completion of the first line therapy. Now, second group which I think is interesting to watch is patients who are early relapse, but in a situation where patients are referred for CAR-T and in the meantime they receive some salvage and they attain a very good PR, or close to CR. Because when you say PR, again, it is the heterogeneous response where you have a good PR, where you get this response everywhere except one single site, or a PR with multiple sites. So these are all heterogeneous groups. So there is a CIBMTR data which has shown that if in those good PR patients, probably transplant will still be better in early relapse as well. But that will be a small fraction of patients. But definitely in early relapse is something which CAR-T has really replaced it. But late relapse, definitely we need more data. But late relapse still salvage chemo and transplant is the standard of care.
Given an option to you for late relapse, CAR-T versus auto transplant?
No. So for CAR-T, so unless we get data for that, definitely it is autologous transplant. If the patients receive salvage, if they do not attain a good response, which is required for transplant, then definitely at that time CAR-T, but not as a late relapse and directly going into CAR-T. That is not something which I will suggest.
Next slide, please. So, this was a CIBMTR data that Dr. Nayak was talking about. This basically, compared autologous transplant versus chimeric antigen receptor T cell therapy for relapsed DLBCL patients who were in partial remission after the salvage therapy. Next slide, please. And it does show that if you have a relapsed refractory DLBCL and if you attain PR with salvage chemotherapy, then autologous transplant was actually superior to CAR-T cell therapy. So as he rightly pointed out, for late relapses, salvage therapy, and if you are responding to that, auto transplant still holds water. Next slide. And this is again, the CIBMTR data was retrospective data where all incomers were included. If we wanted to compare CAR-T with patients who were with PR with less than 2 lines of therapy, their autologous transplant was starting to lose its advantage over CAR-T. Autologous transplant was not inferior, but it was not superior if you took less than 2 cycles of therapy and PR attained. Next cycle. So autologous transplant still holds water. So the conclusion of this data was autologous transplant is a standard of care in transplant eligible patients with relapsed DLBCL who attain partial remission after salvage therapy. Next slide. Now also, depending upon different preferences, patients receive chemotherapy after relapse for several reasons. They may not meet the eligibility criteria for CAR-T. There's a lack of immediate access that all of us have right now to CAR-T cell therapy. And then there may be an individual patient or physician preference for a particular kind of therapy. So autologous transplants and salvage chemotherapies continue to be important component in this, despite CAR-T being available. Next slide. And this is the ASTCT recommendation. It basically recommends a CAR-T cell therapy for patients with DLBCL who have relapsed within 12 months of the first line treatment. Next slide. Now, if I can ask Dr. Yadav, a patient was planned for a CAR-T cell therapy. However, you gave a salvage and this patient has attained a CR and not PR. Would you still go ahead with CAR-T in this one?
Yes, obviously, salvage chemotherapy prior to CAR-T cell therapy is definitely required for the lower disease load and lower incidence of ICANS or CRS. And at patient without detectable lymphoma at the time of CAR-T cell therapy had excellent outcomes. So that's why definitely we will go.
Yeah. Next slide, please. So this is the data where CAR-T was attempted in patients who were actually in remission, and they found that if patients was in remission and CR, their responses were far superior to patients who received CAR-T when the diseases were not in remission or PR. So basically, as Dr. Yadav has pointed out, lower the disease burden, better were the responses with the CAR-T. Next slide. Now, Dr. Avriti, we also see that bispecific antibodies are, doing rounds these days, and there are a lot of such molecules available nowadays. Next slide. So Dr. Baveja, would you want to differentiate between CAR-T versus BiTE for DLBCL?
Yes,
Next slide, please.
So basically, BiTE is the bispecific T-cell engager therapy and CAR T-cell therapy. In this, CAR T-cell therapy is a procedure one time done. It will the responses will stay for a longer time. Whereas in BiTE therapy, it's basically a step-up type of a therapy where weekly regimens are given to the patient and the responses would be variable. Currently, at present, the BiTE therapy is basically an off-shell therapy, and it has, though the disadvantages of the BiTE cell therapy are less than the CAR T cell therapy, but still, in both the cases, cost remains an issue at present.
So I think,
and currently we have data supporting which have a tendency for giving cure in lymphomas with the use of CAR T cell therapy.
Given an option, both are available. What will be your choice? CAR-T versus BiTE?
Maybe CAR T cell therapy.
Yeah. All right. So again, as you pointed, CAR-T is one-time treatment. Once you are done, you are done. While the advantage of BiTE, it's available off-the-shelf kind of thing like any other molecule. Next slide, please. Dr. Ashish, when do you consider allogeneic hematopoietic cell transplant in DLBCL? Next slide.
Sir, if patient is relapsing on the after autologous stem cell transplant, so basically we need a high intensive salvage chemo. So preferably patient relapsing post autologous stem cell transplant will proceed for the allogeneic stem cell transplant.
Yes. So I think in today's time, the main two indications for allo transplant in DLBCL is, as is rightly pointed out, if someone has relapsed after autologous transplant, you want to consolidate with allo transplant. That's one of the curative options still available. And second, if you are not able to do an auto transplant for whatever reason, so there may be patients with persistent marrow involvement, difficult to clear disease out of that, or there may be patients who are poor mobilizers, you are not able to mobilize stem cell. These are also the patient population where you would probably proceed with allo. But the predominant indication is if someone who has relapsed after an autologous transplant, as rightly pointed out. Next slide, please. If I can ask Dr. Nayak, what about the novel agents in DLBCL? Next slide, please. I think he's not available. Dr. Yadav, you could take over.
There are many drugs which are under trial in all form as a treatment, as a conjugate in salvage chemotherapy, as a maintenance, like ibrutinib, venetoclax, lenalidomide. All three have very good data. Ibrutinib as a maintenance and lenalidomide as a maintenance, it has been published. There are other drugs like vorinostat, nivolumab, and combination of all drugs. They are under trial with various combination. I think three drugs which are important in some subset of DLBCL, especially for double hit or non-GCB group: ibrutinib, venetoclax, and lenalidomide.
Yeah, rightly pointed out. Next slide, please. Before we talk about this, a question open to all panelists. Somehow it has been missed from this slide set. If we have given one kind of salvage therapy, let us say DAP or ICE or GDP, depending upon the center preference, and if a patient has not responded to that, what are the chances? So should we be giving a second kind of salvage? So let us say ICE, then we give DAP, we give GDP, something like that. And do we expect any kind of responses there? Anyone could pitch in.
Definitely, with the availability of polatuzumab, we can try for the immunotherapy combination of polatuzumab, bendamustine, rituximab. That can be an option for such patients.
Yeah, no. The question is more for the chemo part, not the ADCs and all.
So
no second chemo. Usually this patient do very poorly in second salvage. There is no point in giving toxicity of chemotherapy to those patients. Immunotherapy is the way to go, or CAR T-cell therapy.
Yeah. So, in a British Journal of Hematology, I think maybe 2-3 years back, there was an article published on this, that if a patient fails, and that's the general impression that I also had, like you said, if somebody is failing one kind of salvage, probably there is no point giving second kind of salvage. But the data does suggest that if you use second kind of salvage, so you use DAP, you give GDP or DAP, you give ICE or vice versa, you're still able to bring about 40-45% patients in some kind of remission, which is PR and above. That's the overall response rate. And a small proportion of these may still be able to proceed to transplant. So the actual number, if you look, medians are misleading, the numbers are higher. But if you look at the 2-year, EFS in these patients, that is about 20%. But you may still be able to salvage a smaller proportion. Of course, when we have an option of polatuzumab and other, that would be the right way to go. So before we conclude this session, I'll just want to summarize how do we optimize the therapy in DLBCL today. We basically look at if somebody is relapsing very early, less than 12 months from the previous, we see whether the patient is eligible for CAR T or not. If the patient is eligible, we give CAR T cell therapy, which is now approved as a second-line therapy. And we are able to cure probably 20% of all upcoming. If they are not eligible for CAR T and it was an early relapse, then we use selinexor, ibrutinib, venetoclax, polatuzumab, a host of other medications are doing the rounds these days. If somebody were a late relapse, then as we had discussed during the session, that a salvage chemotherapy followed by an autologous transplant, even though the proportion of patients who would be on this path would be smaller, but you are still able to cure a proportion of these patients. Next slide, please. So to conclude, the field of relapsed refractory DLBCL is dynamic, and CAR T cell therapies are promising options for difficult to treat early relapsers. Polatuzumab, tafasitamab, lenalidomide combination, several other molecules are coming which are pretty safe to be used. Bispecific antibodies are again promising agents for treatment of patients. Now every medicine has a niche for a particular kind of patient. As of now, limited data is available on the best sequencing approach, which agent to use first. With this, I would want to conclude this session and thank my panelists. They have been to the point and to the time. They have been very decent and well-behaved panelists. Thank you so much.
Thank you, Dr. Rahul, for that excellent moderation on relapsed refractory DLBCL. I'm also thankful to our panelists for their excellent panel discussion. So now I invite Dr. Brigadier Ajay Sharma sir. He is Director, Head of Department of Hematology and Oncology at Paras Hospital, Panchkula. I also invite on second chairperson, Dr. Devesh Goyal. He is Senior Consultant Medical Oncologist at Fortis Hospital, Jaipur. Over to chairperson for the next session.
Good evening. Thank you, Dr. Upender, for this opportunity for sharing the platform here with all of you and all of the friends over here. And good evening, everybody. I think Dr. Upender has taken a big initiative, and I think we should have more of such meetings from various centers. Now, starting with the next session today, I think Dr. Dharma, I can't see his name here, but I'm sure he's there in the on this platform. Dr. Dharma Chaudhary, who needs no introduction, who is I would say synonymous with a few things: the bone marrow transplant, hematology. For quite some time, BLK, and now Sana International Hospital. He's the director of the bone marrow transplant program over there. Today, he's going to talk to us about a very tough topic, that is MDS, but it's being made more and more easy as the time goes. There are a lot of activity in the EHA this year where actually a lot of data was presented and focus was on a couple of agents in the low-risk MDS, luspatercept, and that the medalist trial data was presented, and many other aspects which I'm sure Dr. Dharma is going to touch upon in his presentation on MDS from the lens of EHA. Dr. Dharma, please.
Hi, good evening, sir. Thank you for your kind introduction. Am I audible, sir?
Yes, very well, very well.
Yeah.
Thank you.
So thank you for kind introduction, and I'll thanks Upendra for asking to deliver this talk, clinical update in MDS from the lens of EHA, and I'll just slides. Not
Yeah,
moving.
somebody needs to, I think, yes, that's
No,
fine.
I'm just doing. So, the MDS, we know it's the most difficult disease to treat, and in the current EHA and or I would say 2023, how we should approach MDS. So this is for all the postgraduate and all the clinician. This is new MDS WHO classification, and I think for future we should label our patient with these, nomenclature. So MDS is typically put into two categories by WHO: MDS with defining genetic abnormalities and MDS morphologically. So there are three specific MDS defining categories with genetic abnormality: MDS with low blast count and isolated 5q deletion, MDS with low blast count with SF3B1 mutation, and MDS with the biallelic T53 inactivation. And morphologically, they define as MDS with low blast, MDS hypoplastic, which is MDS-H, MDS with increased blast, which MDS-IB, instead of like earlier we used to write RAEB, so IB1 and IB2, and any blast, if this is present with the fibrosis, MDS with fibrosis is to be, is separate entity. So when you look at the NGS becomes standard of, the test, because you have to have a genetic abnormality defining MDS. So then moving to, there's a cytogenetic scoring system in myelodysplastic syndrome. And what this tells, there are 5 categories: the very good, which is presence of deletion 11q or presence of Y chromosome; good, which is most of the normal cytogenetics; intermediate, poor, and very poor, which is more than 3 complex abnormality. So if you look at the very good cytogenetic score, and good and very good, so the median overall survival is ranging from 50 to 60 months. A poor risk or very poor survival is between 5 to 15 months. The intermediate category of cytogenetic scoring system, which gives a 25 months, 5-year survival. So you have to have a good cytogenetics for myelodysplastic syndrome when you're treating and classifying these agents. We should also know these 3 entities when you're looking for MDS and treating them. So there's one is CHIP, ICUS, and CCUS. So what is difference between, what is CHIP? CHIP is clonal hematopoiesis of indeterminate potential, which doesn't have cytopenia, doesn't have dysplasia, but can have somatic mutation with very low risk of progression. When you have ICUS, that is idiopathic cytopenia of undetermined significance, you can have cytopenia, that is by the name, without any dysplasia or minimum dysplasia, no somatic mutation. The risk for progression in ICUS is also low. CCUS, with the clonal cytopenia of undetermined significance, you have cytopenia and you have clonal somatic mutation, and it has very high risk of progression toward MDS and leukemia. So these 3 entities should not be treated, they should be monitored if you are coming across with this. Once you have MDS, you have to treat this entity. And with the NGS, now you see SF3B1 mutation, TAT2 mutation, ASXL, and SRSF mutation. These 4 are really like MDS defining mutation, which is the present in more than 10% of patients. So in the current and future, the NGS possibly should be done for every patient where the cytopenias are there and you're labeling MDS. And in 2023, if you look at the proposed algorithm for patients who are diagnosed MDS and those who are lower risk patients who have IPSS low or intermediate one, they of any age, they should be treated with the either blood transfusion along with iron chelation or growth factor, whether erythropoietin or GCSF or even the platelet growth factor like altromomab and romiplostin. Luspatercept is new kid in block, which I will discuss later, but has been approved for lower risk MDS, and HFH and lenalidomide are considered along with immunomodulation, particularly hypoplastic MDS. A patient, those who have high risk category with higher IPSS score, intermediate 2 or high, if they are younger than 70 years, those who are fit, may consider intensive chemotherapy or HMA followed by allotransplant. Any patient who is more than 70, one should always consider HMA first. Intensive chemotherapy should not be considered for most of the patients, but some patients who are fit, they can still consider for allotransplant after giving intensive therapy with the non-myeloablative regime. So this is what we know in 2023 as a clinical practice. And there are few recent combination in high-risk MDS has been, in the pipeline, and particular interest if you look at Asia along with venetoclax and magrolimab, which I will discuss later, which can give you, look at 80, almost 70% plus the overall response rate, including the 20 to 30% of CR rate, which is very good in considering these patients, those who are very high risk. So with this background, in this EHA update, I'll possibly cover these 5 molecules of clinical importance: luspatercept, imetelstat, oral azacitidine, magrolimab, and sedaconda, and I'll come one by one in the period. So the one abstract which has actually proven the COMMAND-3 trial, phase 3 study evaluating luspatercept versus epoetin alpha in ESA naive transfusion dependent patient with lower risk MDS. And what this COMMAND-3 study say, they presented earlier in ESCO, which showed the nearly twice as many patients treated with Reblozyl, which is a brand name for luspatercept, achieved superior transfusion independence with concurrent hemoglobin increase was in compared to epoetin alpha. And this luspatercept demonstrated durable response with nearly 2.5 year median transfusion independence, 1 year longer than this EPO. So in this study, the primary endpoint of this COMMAND study was RBC transfusion independence for 12 weeks with a mean hemoglobin increase of 1.5 gram per deciliter or more. And secondary endpoint include erythroid response at least 8 weeks during first to 24 weeks of study, RBC transfusion independence of the 12 weeks, and RBC transfusion independence at 24 weeks. So they included all the adult patients who are more than 18 years with the lower MDS who require transfusion. They did 1-to-1 randomized, and luspatercept was used from 1 milligram per kilogram to 1.7 milligram per kilogram every 3 weekly, along with epoetin alpha in the control arm. So what the results show, the almost 150 patients in each arm with median treatment duration of 41 weeks and 27 weeks in the other arm. The primary endpoint achieved with the almost 60% with the luspatercept versus 30% in the EPO arm. The secondary endpoint, which is hematopoietic improvement in erythroid increase of at least 8 weeks, was achieved in around 75% in the luspatercept group versus 50% in the EPO group. And those patients who are treated with luspatercept achieved more durable response in compared to EPO, with a median duration of response of RBC transfusion independence more than 12 weeks of 126 weeks versus 77 weeks in EPO arm. So within the first 24 weeks of the treatment, RBC transfusion independence of at least 24 weeks was achieved by 50% in the luspatercept versus 30% in epoetin alpha group. So all are statistically significant, and these results have been presented in the just previous ASCO, and what they found, almost 60% patients achieved transfusion independence in compared to epoetin group. And the secondary endpoint, as I said, the 50% versus 75% in the luspatercept group. And the acceptable, the adverse event. And when you look at in this command study, which is what prolongation of the ASCO presentation, they looked at the MDS defining this all mutation, and in all group, the luspatercept is, the response is much better in compared to epoetin alpha, whether you look at ASXL, DNMT1, or SF3B mutation. So everywhere the luspatercept have proven superior to epoetin alpha in the treatment naive MDS patients. And this is the pictorial curve. In the first, the proportion of the patient who achieved primary and secondary endpoint as study point. So RBC transfusion independence at 12 weeks, the hematopoietic erythroid response at 8 weeks, 24 weeks. So wherever you look at, the luspatercept scored higher, and when you look at the plot, the forest curve, this all favor the luspatercept. And as I said in the previous slide, that the MDS defining this genetic somatic mutation, the luspatercept had proven with the ASXL, DNMT3, SF3B1. So luspatercept had proven superior, and this study command 3 has FDA has approved 3 days back luspatercept as a first-line treatment for anemia in adult with very low to intermediate risk MDS who may require regular RBC transfusion and erythropoiesis stimulating agent naive patients. So just 3 days back or 4 days back, the Reblozyl has been approved for this treatment naive patient. And just this is background I give you. The Reblozyl has already been approved adult patient with beta thalassemia major who are transfusion dependent and anemia, failing ESA and requiring 2 or more red blood unit over 8 weeks in the adult patient with the low risk MDS like MDS RS or MDS MPN RS and thrombocytosis. So this is the third indication which is FDA approval comes with the command 3 study. So second, the abstract I'll touch upon this continuous transfusion independence with the immediate state in heavily transfusion non-deletion 5q lower risk MDS relapse refractory to ESA in emerge phase 3 study. And we know that we have an unmet need for patients who fail ESA in the lower risk MDS. And in emerge phase 2 trial, the treatment with imetelstat, which is a telomerase inhibitor, resulted in prolonged durable transfusion independence across the broad range of heavily RBC transfusion dependent ESA relapsed or refractory non-del 5q low risk MDS patient naive to lenalidomide and hypomethylating agent. And in this study, the aim was to evaluate the efficacy and safety of imetelstat versus placebo, and the method they adopted almost similar to luspatercept study. So the primary endpoint of the 8-week transfusion independence and the subgroup analysis IPSS risk, prior transfusion burden, ring sideroblast status, and secondary endpoint include 24 weeks transfusion independence rate, transfusion independent duration, and hematological improvement erythroid rate. So this is HIE rate and change in mutation burden by variant allele frequency has been. So what the results shows, primary endpoint was met in 40% of patients versus 15% patients who are receiving imetelstat. The rate of 8-week transfusion independence was significantly higher with imetelstat. The median transfusion duration was 50 weeks plus with imetelstat versus 13 weeks in placebo arm. 24 weeks transfusion independence was achieved in nearly around 30% of patients in compared to 3% in the placebo arm. And erythroid response was achieved in 40% plus patient in the immetal state in compared to 13% patient in the placebo arm, and all have significant p-value. So the variant allele frequency reduction is seen in 3 genes, which I said MDS defining, both all 3, SF3B1, TAT2, and DNMT3A and ASXL. So SF3B1 VF reduction correlated with the longer transfusion independent immetal state treated patient. There was no new safety signal was identified in this emerged B3. So this is the second molecule you have after this luspatercept for patients who are failing with ESA. So in summary, what they say, immetal state demonstrated statistically significant and clinically meaningful efficacy with robust 8 weeks, 24 weeks, and 1 year transfusion independence rate and durable continuous transfusion independence. For the low-risk MDS patient population, almost 1/5 of immetal state treated patients achieve continuous transfusion independence for more than 1 year, representing substantial relief from transfusion-associated complications. VF reduction and its correlation to clinical endpoint, including durable transfusion independence, support immetal state is disease-modifying potential. So safety results were consistent with the prior reports. So immetal state treatment provides significant clinical benefit to heavily transfusion-dependent, low-risk MDS patient population in need of novel therapy. So this is the again cartoon almost similar like the luspatercept study group. The 8-week transfusion independence is almost around 40% patient, 16 weeks is around 30% plus patient, 24 weeks and nearly around 28%, and even more than 1 year if you look at the almost 18% of patients will be continuously on transfusion independence, those who are receiving immetal state. So next, the molecule, I will come to the phase 2-3 trial of oral azacitidine in patient with the low or intermediate risk in MDS. So this is a new trial which has presented in this EHA. The trial, they put the trial, the aim is phase 2-3 trial will evaluate the safety and efficacy of the 14 days oral AZA regime in patient with the IPSS defined low or intermediate risk. So we all know this AZA and...
Sir, kindly conclude your talk in 2 minutes, please.
Sure. So this is because those patients who are getting the long-term therapy, the oral AZA design is for 300 and 200 milligram. Another molecule is CD47A, the antibody, the magrolimab. So targeting CD47 has been, the aim in the AML patient, those who are high-risk patients, and the magrolimab in combination with azacitidine has proven the better, including the almost 50% of patients achieving complete cytotoxic response and MRD negative in AML, in MDS around 20% MDS negative MRD and CCR response in 35%. So I'll just conclude in 2 minutes because so this is the response rate is in the AML in mutant TP53 is almost around 75% and CR of 50%. So magrolimab is another gonna be a kid on block to treat these high risk MDS and AML patients. The sedazudine, I'll just put the last word because the AZA like decitabine also has to be for long term and it cannot be given oral. So sedazudine is the CDA inhibitor and which can safely combine with the decitabine. And this can be another hope for MDS patients who need prolonged therapy with the oral response rate of almost around 65% of patients. So this has been recently approved for this high risk MDS, the low risk MDS, RA, RS, RAB and CML, and intermediate high risk MDS. So I thanks the organizer for giving opportunity and will take any question if. Dr. Ajay, your voice is on mute.
Thanks, Dr. Dharma, for a very comprehensive coverage. I know this topic is very big and the time constraints are there. I'm getting the indication about the time constraints. So I think we'll leave the question answers to the chat box. You can actually communicate with Dr. Dharma. Can we move on, Mr. Abhimanyu, for the next talk? Once again, Dr. Rama, thanks a lot for this wonderful talk.
Thank you, sir.
Thank you. So over to Dr. Upendra and his team. Mr. Abhimanyu, please.
Thanks, Dr. Ajay sir, for that for chairing that session. Thanks, Dr. Dharma Chaudhary, for that excellent talk on how we can treat MDS patients, the updates from the year. Now I invite our two chairperson, my colleagues and friends at Bhagwan Mahavir Cancer Hospital. They are senior consultant hematologist and hemato-oncologist at Bhagwan Mahavir Cancer Hospital. I invite Dr. Asim Samar and Dr. Tara Chand Gupta to chair next in the last session of this today's seminar. Over to Dr. Tara Chand Gupta and Dr. Asim Samar. Dr. Tara and Asim, whether you are there?
So they are not joined. I think they have some issues. So kindly you chair the session for the next.
So now I invite Dr. Abriti Baveja. She is a consultant hematologist and hemato-oncologist and bone marrow transplant physician at Dehradun. She will be giving a talk on clinical updates in the management of ALL patients. Over to Dr. Abriti Baveja.
Thank you very much, sir, for inviting me here for the session. So please, can you share my slides?
Sure, ma'am. Can we share ma'am slides? Nishan?
So I'll be talking about the updates in the management of acute lymphoblastic leukemia. Next. Next slide. So in ALL, we know that with time, the survival outcomes in the pediatric age group have been improving. Next slide. And this is possibly because of the understanding of the nature of the disease. And since initially AML was considered to be a very heterogeneous disease, but now ALL with the study of the genetic markers is coming up to be a heterogeneous disease. Next slide. And in different age groups, there are different genetic markers which are predominant, and the outcomes vary in different age group according to the predominance of the genetic markers which are seen in this in the different age groups. Next slide. Next slide. So this is how we can see that even with the same scenario, we have different outcomes. And the cure rate and survival outcomes in patients of ALL have been improving because of the better understanding of the disease, incorporation of the MRD testing, refinement of the risk-adapted treatment algorithms, and advent of the new target agents. Next. And we all know about the various factors which are the clinical parameters, the cytogenetic, and the various MRD parameters which have been affecting the outcomes of pediatric as well as adult ALL patients. Next slide. So basically, we all know the overview of the disease. We have been using, in general, the induction, consolidation, and maintenance phase along with CNS therapy. And next slide. And on the basis of various, next slide. On the basis of various groups, there are different trials, and on the basis of different trials, we are using different types of regime depending upon our experiences. So now, since it's updating the things, it's about targeting the ideal therapeutic agent in ALL, which depends entirely upon various expression of antigens on the normal cells, the density of expression, and the percentage of blasts which are expressing the antigens. Next slide. So we have multiple targets in BLL, TLL, and these targets are being explored in various ways in relapsed refractory settings and now in the upfront settings also. Next. And the most, next slide. And the most common targets which we are targeting are the CD20, CD19, and CD22. So we have an option of allogenic stem cell transplant, rituximab, blina, inotuzumab, then CAR T cell therapy at present in our armarium for the management of ALL. Next slide. And with the use of pH TKIs in CML, we know the use and benefit of TKIs in pH positive disorders. And even in B-cell disorders, addition of rituximab in certain scenarios may help us in improving the outcomes, and it has been shown up in various randomized controlled trials. And even in BCR-ABL like ALL, there has been a target, there have multiple targets, and multiple targets according to the genetic makeup could be addressed. Next slide. So what we have in pH positive ALL is the various backbones with chemotherapy, which include imatinib, dasatinib, nilotinib, ponatinib, and ponatinib plus chemotherapy combinations. And these have got very good CR rates. And the ponatinib arm, along with hyper-CVAD or chemotherapy, has very good outcomes, and it is replacing the need of bone marrow transplant. Next slide. And this is being used in elderly patients with low intensity induction as well. Then next slide. So now comes the role. Next slide. Now comes the role of blina with TKI inhibitors. So blina and inotuzumab has been used in various trials for the management of pH positive ALL, or blina is being used with some TKIs in elderly patients so as to have good outcomes. Now, when we talk about the pH negative ALL, though pH positive ALL per se is a targeted, we already have a targeted therapy, and in that also we are integrating other targets apart from the TKI. In pH negative ALL also we have certain trials which are supporting the use of blina as well as inotuzumab, either singly or in combination in the background of adults with newly diagnosed ALL, and they have got nearly 100% CR rates and got very good overall survival rate. For example, the combination of blina and inotuzumab, it has got 1 year survival of about 100%. Next. And in elderly patients where we are always at a difficulty of giving full dose chemotherapy, the frontline blina and inotuzumab combinations are providing good CR rates, high MRD negativity rates, and good overall survival rates. Next slide. So this is one of the examples of the Alliance trial in which the induction chemotherapy is the base INO, and followed by incorporating blina in the consolidation regime. In this study, they had given INO2 in the dose of 0.8, 0.5, and 0.5 mg per meter square at day 1, 8, and 15. And response assessment was done at day 18 and day 21, along with CNS prophylaxis IT 8 doses. Now, once there has been an adequate there has been adequate cytoreduction, if the patients were in CR, the patients were given, despite of the fact, like if the patient was in CR, they were given inotuzumab in the dose of 0.5, 0.5, and 0.5, again at every 15 days interval. And if it was not in CR, then it was given in the dose of 0.8, 0.5, and 0.5. And again, response assessment was done. And depending upon the results, the consolidation has been provided to the patient. And even those patients who failed to achieve the ALL cytoreduction, they have received blina 2 cycles for 42 days. And then a response assessment was done. Next slide. So in this study, we could conclude that the 1 year event-free survival was approximately 75%, and 1 year overall survival was around 84%. And from the baseline characters also, we can see that the median age of the patients who received was around 60 to was 71, with a range of 60 to 84. And the patients had median CD22 expression was 92%, and there were 12 events in this, with 9 relapses, 2 deaths, and 1 death without remission. So the common grade 3 plus side effects were observed in more than 10% patients, and this were neutropenia, thrombocytopenias, anemias, and leukopenias, etc. Next slide. So next slide. So in total, this combination seems to be a good hope in elderly patients, where this combination can be used where we are not able to use the high dose chemotherapy. So whenever we are exhausted with the sources of chemotherapy, or the patients who are the upfront candidates for transplant, we have to offer them transplant. And these cases includes infantile ALL, the ones with high risk features, or the presence of Icaros mutation, or presence of TCF3 HLF mutations. And all these patients are given transplant in CR1. Next slide. And even in TLL, those who have induction failure and those who have a positive MRD, in those cases, we provide some therapy, and then we go for transplant. And if it is, in certain cases, even after consolidation, we are providing patients the option of bone marrow stem cell transplant. Next slide. So the various groups, according to they have defined the various criteria for going for various definitions of relapses. And then next slide. And we again, at the time of relapse, have an option of chemotherapy, enrollment in clinical trial, treatment with CD19 or CD22 antibody targeted therapy, or CAR T-cell therapy. Next slide. In PH positive BLL, the NCCN guidelines recommend that with the presence of ABL1, we should go for ABL1 kinase domain mutation testing, and then the patient can get an option of clinical trials, TKI plus minus chemotherapy plus minus steroid, or blina plus minus TKI, inotuzumab plus minus TKI, then CAR T-cell therapy. In PH negative BLL, we have to molecularly characterize the patient, and then we have an option of clinical trials, blina, inotuzumab, CAR T-cell therapy, and chemotherapy. And in TLL, most of the time, clinical trials are being considered, and following that, patient may be considered for stem cell transplant. Next slide. So most of the time, the data for inotuzumab have been very nice, because it is an agent apart from chemotherapy that is easily available. Currently, though we have cost issues, but still select patients can get this option in our country as well. So this in its phase 2 studies have shown an overall response rate of approximately 60%. Next slide. And it has even shown the good CR rate in comparison to the standard of care therapy, and presence of MRD negativity in responders. Next slide. And with the increasing the duration of cycles, even till 3 cycles, patients still get a response with inotuzumab. After 3 cycles, if the patient is not getting response, in that case, the drug won't work much. Next. And these are the bar diagrams which are showing that how the outcomes are being changed even with increasing the duration of cycles. Next slide. So the progression-free survival of inotuzumab is better than the standard of arm. Next slide. And even the duration of remission is better. Next slide. So trials have been done with the where inotuzumab has been followed up by the transplant, and the candidates who have been eligible to go for transplant after this therapy is better than the standard of care therapy. Next. And even the long-term overall survival is better in this group. Next. So, most of the side effects are manageable, and the more threatening side effects are comparatively less in the inotuzumab AM, and these agents can be given, even on the daycare basis. Next slide. So now the question arises, since with the advent of data for CAR T cell therapy, we are always at we have a choice whether to go for CAR T cell therapy, whether to go for allogenic stem cell transplant, what are the merits, what are the demerits of the both regimes, which have been supported by the various clinical trials which have been done. Next. Next slide. So allogenic stem cell transplant are the main main modality of the treatment. Next slide. And we have seen that next slide. And we have seen that the outcomes with transplants are better than without going for the chemotherapy. With only chemotherapy, transplants have been better. Next slide. Next slide. Next slide. So even with transplant, next slide, even with transplant, there are certain chances that we are not able to address certain problems. Though still transplant is a standard of choice, but still there are shortcomings in certain high-risk scenarios where stem cell transplant is not answering the problem of relapse of ALL patients. Next slide. These includes the patients which have hypodiploidy. Next slide. These are the certain outcomes from various trials which have shown that in certain scenarios, for example, hypodiploidy, in cases of induction failure, in cases of early relapse, we can see that even without transplant, outcomes are same only. We don't get much benefit with addition of transplant alone. We need something much more beyond transplant. Next slide. So in the this answer was given by CAR T cell therapy. Next slide. And it has been evolving since 1959. Next slide. And now we have approved drugs for many for certain relapse and refractory conditions. Next slide. And we have different generations of CARs which are addressing this problem. Next slide. The FDA approved current indications are in less than 25 years of age, second or bone marrow or extramedullary relapse or refractory disease. And the other ones are primary induction failure, early relapse after achieving first CR, and adult patients with relapsed refractory BLL. Next slide. So there have been plethora of trials which have been done for the CAR T cell therapy, and they have got variable CR rates ranging from approximately 50% to 90%, and even in certain cases there has been MRD negativity. Next. So there are various targets for CAR T cell therapy, which include CD19, CD20, CD22, CD4, CD7, CD38, BCMA, etc. in overall in hematological malignancies, whereas the most explored in hematological malignancies in the B cell scenario is more of CD19 and CD22. Next slide. And these are the trials which have been reported in pediatric as well as adult population. Next slides. And they have shown that there has been a 40 to 90% outcomes in these cases. So whenever we compare about what to choose between allogenic transplant and CAR T cell therapy, there are certain indications in which allogenic stem cell transplant could be the priority, that could be the high risk CR1, and in certain cases also CR2, and post-CAR T cell in post-CAR T cell therapy, in which there has been an early loss of the B cells. And in these cases, we can see that with allogenic stem cell transplant, overall the survival rates at is around 30 to 60% at 3 years and 60 to 75% at 3 years in pediatric population, and for, with active disease 20% at 3 years. And overall survival with CAR T cell therapy remains to be around 40 to 70% at 2 years. However, there are different subset of problems and toxicities which are associated with the both the regimes, which makes one procedure better over the other procedure. Next slide. And the answer to the solution is also being studied by changing and modulating the CARs, the types of agents they are being using, the targets they are being using, and thus the problems of persistence or B cell loss may be addressed in future, and the results may be evident in our future trials. Next slide. So whenever we are talking about ALL, that the or hematological malignancy, no talk is complete about without discussing about venetoclax for those particular hematological malignancies. It is coming up as a new drug, which is which many people eye on. So venetoclax has got role in ALL as well, and especially in cases of ETP ALL. Next slide. And in case of in ALL with MLL expression, where high levels of BCL2, VAX, and VIM are expressed. There have been, next slide, there have been trials. There have been trials in combination with venetoclax with mini CVAD, venetoclax with hyper CVAD, and they have got approximately 53% responses and overall response rate of approximately 65%. Next slide. So, sorry for this busy slide. I guess there has been a problem due to interpretation. So the take-home message is that MRD-based appropriate intensification is most important in the management of ALL. Adults, especially hypodeployed and persistent MRD positivity, do need a transplant, but we need to move out of the transplant scenario, because in long term the outcomes are not that great. Apart from the small subset, SCT does not add benefit over MRD based therapies. Then there are certain immunotherapies which are coming up in a good pace, but they have toxicities, though they are manageable. But the main problem is the financial toxicity, which is related to the CAR T cell therapy, which makes it distant for us for use at present. Next slide. Thank you.
Thank you, Dr. Avriti Babeja, for that excellent talk on how we can manage ALL patients. Updates from here. So today we had excellent presentations from all the speakers, well on time. So today we have discussed what had happened about EHA Frankfurt, Germany in July, from 8th to 11th July this year. And we have discussed with our speakers about the various aspects of hematology, about acute leukemias, chronic leukemias, and lymphomas. First session was on ALL, was on AML. And we had an excellent talk by Dr. Meet Kumar on the immunotherapy approaches in AML. He highlighted us with the use of CTLA-4 inhibitors, ipilimumab and tremelimumab, use of PD-L1 and PD-L1 inhibitors, drug like nivolumab in combination with the chemotherapy, role of azacitidine with ipilimumab, with nivolumab, He also talked about anti-CD33 monoclonal antibody like gemtuzumab oxazolizine, and also newer anti-CD33 monoclonal antibody, limtuzumab. He also talked about anti-CD123 monoclonal antibody, talapotuzumab. Also the use of dendritic cell vaccine, CAR T-cell therapy in the treatment of AML patients. Then we had a second talk by Dr. Isha Kaul. She talked about the novel therapeutic approaches in the AML patients, the use of triple combination with azacitidine, venetoclax, and gilteritinib in the newly diagnosed AML patients with FLT3 mutated status. So she also talked about Morpho Trial, wherein gilteritinib was used as a post-transplant maintenance therapy in patients with FLT3 mutated AML patients. The relapse survival was not better in this subset of patients, so this was a negative trial. Also a QV trial study where chemotherapy was combined with quizartinib, and it was compared with placebo in adult patients with newly diagnosed AML having FLT3 ITD wild type AML patients. This was also a negative trial. Then she talked about use of venetoclax plus hypomelanitic agent, followed by allogeneic stem cell transplantation in older patients of AML. So they showed longer outcome benefit as compared to the chemotherapy arm when these patients were transplanted with the use of venetoclax plus HMA. She also talked about APML or oral triple A regime, wherein ATO, ATRA, and ascorbic acid was tried in newly diagnosed AML patients, AML M3 patients, showed excellent clinical and molecular responses with durable remission. Then third talk was by Dr. Amrita Ramaswamy. She talked about the how we can optimize treatment strategy in the patient of CLL. So she showed that now with the present scenario in 2023, we have a limited role of chemotherapy, chemo plus immunotherapy in CLL patients. Only some subset of patients where they are TP53 negative, 17p negative, and IgHV mutated patient on those patients who are young and fit. Only those subset of patient immunotherapy is an option. For rest, all of the patient now we have BTK inhibitor plus minus and anti-CD monoclonal antibody. Then he showed in the relapse refractory setting role of venetoclax plus rituximab with better PFS benefit as compared to the bendamustine and rituximab. Then fixed duration treatment option in patients of CLL with venetoclax plus BTK inhibitor was talked about by her. Then our fourth talk, we had a talk by Dr. Sachin Jadhav on how we can treat DLBCL in the first line setting. So as of now, in today's setting, we have RCHOP as the backbone of therapy for all patients of DLBCL. So stage 1-2 disease, non-bulky disease, 4 cycles of RCHOP, but for bulky disease, 6 cycles of RCHOP plus ISRT. For stage 3-4 disease, 6 cycles of RCHOP plus minus ISRT. Adult patients, they are having cardiac comorbidities, frail patients, those patients, ibrutinib, lenalidomide, rituximab can be tried. For those patients who are fit, having good cardiac performance status, mini RCHOP is an option and can be tried for those patients. Then fifth talk was by Dr. Shruti Toshniwal on the relapsed refractory DLBCL, how we can achieve durable remission. So those patients who relapse less than 12 months, the CAR T-cell therapy is the preferable option for those subset of patients, because these patients, they don't behave, don't have good survival benefit when they are given chemotherapy followed by transplantation. For those patients who are relapsed more than 12 years, silence therapy followed by autologous stem cell transplantation is a preferred option. Then she also talked about tafasitamab, that is bispecific antibody, and that was combined with lenalidomide in relapsed refractory setting patients. So better PFS and over benefit was seen in this subset of patients. Role of antibody drug conjugate with polatuzumab when combined with BR showed better PFS benefit with polatuzumab arm as compared to the bendamustine rituximab arm. Then the sixth talk was by then sixth we have a moderate panel discussion by Dr. Rahul Nathani, excellent moderation and excellent panel discussion by our esteemed panelist. Then we had a talk by Dr. Dharma Chaudhary on he updated us on the how we can manage MDS patients, updates from the EHA. So he talked about use of luspatercept imetelstat, oral azacitidine, magrolimab, and cedazuridine. So now we know that he talked about the use of luspatercept, and now we have FDA approval for this as the first line therapy in newly diagnosed patients of MDS, those who are very low risk or intermediate risk, requiring RBC transfusion and are ESA naive. Secondly, imetelstat, telomerase inhibitor used in transfusion-dependent ESA, relapsed refractory non-5q deleted patients who are low risk MDS and naive to LAN and hypomethylating agents in phase 2 study has good response. Oral azacitidine in phase 2 and 3 trials in low patients with low or intermediate risk MDS patients. He also talked about targeting CD47. Monoclonal antibody of this CD47 is magrolimab. When this was combined with azacitidine, had a good response rate in patients with high risk MDS patients. Then the use of oral cedazuridine, that is a CTEDA, cytidine deaminase inhibitor. So now we have FDA approval for this for previously untreated and treated or de novo or secondary MDS patients. Subtype relapse refractory anemia, RARS, RAB1, or low or intermediate 1 or 2 high risk MDS patients, and also in CMML patients. Then we also had a talk by Dr. Avriti Barrecha on clinical updates in the management of ALL. So she talked about that role of current immunotherapies for BLL with inotuzumab, blinatumomab, and CAR T-cell therapy, use of low intensity induction in elderly AML patients, role of ponatinib plus hypercived in pH positive ALL patients with excellent response rates of 80%, negating the use of transplant in such subset of patients. Role of venetoclax for ALL patient is a new horizon, especially in ETBL patients and those patients who are having MLL gene rearrangement. So better responses with venetoclax when it was combined with mini hypercived in relapse refractory setting. So I'm thankful to all to our patron, Dr. Ajay Wafna sir, for his blessings. I'm also thankful to all the chairpersons, speakers, moderators, panelists, all the students, all the delegates who have participated in today's meeting. I'm also thankful to all the academic partners, Johnson & Johnson, Novartis, Pfizer, and Viatris for the contribution towards success of today's conference. I'm thankful to all for making this event a grand success. Now to Tarunji for further proceedings.
Thank you, Dr. Upendra sir, for such a wonderful closings with the key messages. Sir, we invite everyone to join us tomorrow again. This is 3rd September, Sunday. Again, the session starts sharp at 10 a.m. We have excellent speakers, excellent talk. So thank you so very much, everyone. Please log in again at 10 a.m. tomorrow for the next session for the day 2. Thank you. With this,
so I invite all the participants for a virtual dinner. Thank you.
Thank you so much for your